Good morning and Assalamualaikum everyone. A warm welcome to all of you joining us live on the UMMC YouTube channel. Thank you for tuning in to our special webinar in celebration of the International Day of Older Person IDOP 2025. This webinar is organized by the Geriatric Medicine Unit UMMC and aim to promote better understanding of brain health, early detection and the importance of community support for older adults. Our theme this year is Older Person Driving Local and Global Action, Our Aspiration, Our Well-being, Our Rights. This theme recognizes older adults as active agents of change who are essential in shaping policies and building inclusive societies. The theme emphasizes the importance of acknowledging their ongoing contribution, supporting their well-being, and upholding their rights, as they drive progress and possess aspirations that should be central to global development effort. Driving action. The theme highlights that older people are not passive but are active participants in driving change at both local and global level. Aspiration, well-being and rights. It places a spotlight on their personal aspiration, emphasizes the need to protect their well-being and call for the full protection of their rights as reported by United Nations. Inclusivity. This focus is a recognition of their vital role as leaders, mentors and agents of resilience, and aim to foster stronger intergenerational bond for a more inclusive and compassionate future, according to the International Youth Centre and the World Health Organization (WHO). I'm so happy today to see viewers joining us from different places, whether you are watching from home, at work or with your team. Thank you for spending your morning with us. Today's session is all about raising awareness on mild cognitive impairment and dementia, how to recognize early signs, take action and support our loved ones as they age. We've got a great lineup of experts from various fields who will be sharing their insight and practical tips throughout the day. So stay tuned. It's going to be an informative and inspiring session. To kick off our event, I would like to introduce to our speaker, Professor Dr. Tan Maupin, who is Professor in Geriatric Medicine at the University of Malaya. She qualified from the University of Nottingham, United Kingdom. She received her postgraduate training in internal medicine at the Nottingham City Hospital and her higher specialist training in geriatric medicine at Newcastle upon Tyne. After working for 2 years as a consultant geriatrician at the Royal Victoria Infirmary and Freeman Hospital, she was appointed to an academic post at University Malaya. She is the principal investigator of the Transforming Cognitive Frailty into Later Life Self-Sufficiency (AGELAS) program, which is funded by a Ministry of Higher Education long-term research grant scheme. Prof. Tan is the immediate past president of the Malaysian Society of Geriatric Medicine and formerly the Honorary General Secretary of the College of Physicians of Malaysia. She is a member of the World Fall Guideline Developed Group and a core member of the World Fall Society. In addition, she has founded the University of Malaya spin-off Act for Health Sdn Bhd and as Medical Director of the Genting Dementia Day Care Centre and Managed Care Services Sdn Bhd. Let's welcome Professor Dr. Tan Maupin, Geriatric Consultant, to deliver her opening talk titled Why Early Action Matters.
Good morning, everyone. And it's a great pleasure for me to actually provide the introduction to today's event. And thank you very much to our MC. She's definitely a very, very valued member of the team, and I'm sure that she will continue to be a very, very leading light in the field of speech therapy in Malaysia. So thank you very much for actually taking time to listen to us today. Today's program promises to actually deliver on the agenda of the National Dementia Action Plan, which is actually to increase awareness on early dementia. So the National Dementia Action Plan was launched on the 1st of October 2024. And it's supposed to actually plan the roadmap to the management of dementia for Malaysia from 2023 to 2030. And this is on the background of the Global Action Plan for Dementia that was released by the World Health Organization in 2017. So there are particularly 4 thrusts within the National Dementia Action Plan that was launched last year. And the first thrust is, of course, to increase awareness on the disease, and the second one is on management. Now, this year, in 2025, we are really delivering on these trusts because it's very exciting times. We will see huge changes in the delivery of memory services for memory problems in the University of Malaya, and hopefully the University of Malaya will be the leading light towards total transformation of dementia services and management of early memory losses in Malaysia. So this started with a 6 million ringgit contribution from the Ministry of Higher Education in terms of the long-term research grant scheme that was actually awarded to the University of Malaya, and with a project that was also for a program that is led by 4 other project leaders from the University Putra Malaysia through the Malaysian Research Institute for Aging, University Kebangsaan Malaysia through their research centre, which is the Health and Wellness Research Centre, Aged Care, led by Professor Suzana Shaha, the UITM, led by Professor Abu Bakar, which actually looks at the microbiome, so healthy gut bacteria, as well as new ways of actually altering our diet to actually improve our gut health, and that apparently affects our brain health. And also with Monash Malaysia, Professor Tay Paley and the Geron Technology Lab to look at mobility solutions for cognitive frailty. So through these 5 years, we've actually delivered a huge amount of contributions to the community in terms of public awareness, and we've collected data of now over 6,000 individuals throughout 8 states in Malaysia. And with the findings of our study, we hope to inform the early diagnosis of dementia and also effective delivery of multimodal lifestyle intervention, which is just a lifestyle intervention that will actually hopefully prevent the development of dementia, particularly in those with early memory problems. So early memory problems or mild cognitive impairment actually form 20% of our population aged 60 years and over. So if you are aged 60 years and over, you have a 1 in 5 chance of having a problem with your memory. Now, not every one of these individuals will develop dementia. So only 1 in 10 1 in 10 people with early memory problems will actually then progress into dementia per year. And we know that this is an opportune moment where we can actually prevent them getting dementia. So we hope that through today's program, but also in a larger scale through the efforts that's going to be delivered through the University of Malaya and the University of Malaya Medical Centre, our institution will totally transform the landscape by which we approach memory problems in older adults. And also, this can happen to younger adults, so anyone with the potential of developing dementia. It's been a huge struggle internationally because the new disease of dementia didn't really become prominent until we have this issue with global population aging. And as our country has entered the journey of population aging, we crossed a line in 2021 where 15% of our population became 65 years and over, and 7% of our population became 65 years and over. And by 2024, we will cross a line for 15% of our population being aged 65 years and over, and that is when we become an aged population. So preparation for an aged population has become the top of the agenda for the 13th Malaysia Plan, which Malaysia will enter into in 2026, and that will take us on, because it's a 5-year plan, to 2030. So everyone's been glued to the television screens to watch our Prime Minister, Dato' Sri Anwar Ibrahim, deliver the 2026 budget. And we were delighted that the University of Malaya was awarded the Health Metropolis. This was announced in the 2026 budget. So we hope the details of the Health Metropolis will come to light in the very, very near future. And we have great hopes that this will go towards funding a community, a senior living community within the University of Malaya grounds. And our proposal will include a living lab that will actually look at potential innovations and also look at delivery of our research output for Malaysia. So with that, I'm very grateful for this opportunity to share what we've done so far, and this is only the beginning. So it's a very exciting times, and in the next 5 years, we have this plan to actually make aging positive, and also to actually totally transform our landscape when it comes to memory issues, particularly in older adults, but in the whole population. Thank you very much.
Thank you so much, Prof. Tan, for the inspiring opening. It's a great reminder that when it comes to brain health, early action really makes a difference.
Thank you.
For more informative sharing, I would like to introduce to our second speaker, Associate Professor Dr. Nur Izzati Saidun, who is Professor in Geriatric Medicine at the University of Malaya. She received her postgraduate training and her higher specialist training in Geriatric Medicine at University of Malaya. Currently, Dr. Izzati is leading the charge in her research that focuses on blood pressure changes in older adults and understanding the impact of these changes on brain perfusion. Let's welcome Associate Professor Dr. Nur Izzati, Geriatric Consultant, who will share on forgetfulness or something more, understanding MCI.
Okay, thank you. Good morning. Good morning, everybody. It's very early morning, I think just about 9. Thank you for being here with us today, and I'm very delighted that everybody get some time to sit with us and learn a bit more on aging and forgetfulness. So my topic today is on forgetfulness or something more. Well, I'll start with a story, because I think in PJ area or UMMC area, majority of our patients a bit different from the other population in Malaysia. Majority of them very much aware of their situation, so commonly they will come to us very early on. And so MCI is a situation when you will tend to think that you forget things, but not that apparent. So in a way macam rasa tak seingat dulu. Okay, that's the word that usually our elderly people tend to come in and comment on. They feel that they are less alert, or they feel that they are less performing. Usually it occurs, so they come in and saying that 6 months ago, I think for the past 6 months, I've been missing things more often. I've been neglecting things that I usually don't forget that often, and I remember it quite late. So as what Prof. Tan has been saying just now, it is very important to prevent. So small things at early stage, we want to acknowledge very early on. So there's steps that we can do that I want to empower everyone out there to be alert on and take charge on what they need to do next. Okay. Next. So everyone forgets sometimes, they say. I mean, myself, sometimes I forget their names. Maybe after a few years I've not seen someone. You forget certain appointments when you are so busy doing things. And these are not something that very uncommon. But when does it become a sign of something more? That is what we need to know. Early recognition help in terms of planning, treatment, and quality of life. We talk about forgetfulness because early recognition saves independence. Unfortunately, majority of Malaysians still thinks that being forgetful is normal aging, or it's like orang sudah tua kan. So it's not something that we want to our population to take it as something that is normal, because it is not normal. And it's something that we can improve. That's something that we can do to prevent it to become something more sinister. So today our goal is to replace the fear to more understanding what is forgetful and what you can do to interfere or stop the progression of the disease so that you become more independent as you grow older. Next. Okay, this is just a small, it's actually quite overwhelming slide, but it's something that I would want everybody to have a look on the studies that being done. This is a very recent study from 2022 to 2023 talking about mild cognitive impairment in Malaysia particularly, looking into elderly with chronic disease, community adult, and just Malaysian cohort, which is very close to our environment currently. We can see that majority of the time our finding shows that we are very lack in terms of awareness. We don't understand that certain things like diabetics or high salt diet actually increase risk of mild cognitive impairment. Sugary food increase things of mild cognitive impairment, and certain simple things as exercise improve memory. So sometimes we would like to see mild cognitive impairment or forgetfulness not just about brain. It is also about reflection of your whole body health. So when your body are not at their optimum level, does it affect your memory, and also you become forgetful. Next. Okay, mild cognitive impairment is a stage between normal aging and dementia. So you're not demented yet, or you're not having a disease that need to be treated yet, but it's also not a normal memory issue. So a person usually notice there's some memory forgetful, but they can remember, but they can still manage their daily activities. So not everyone with mild cognitive impairment would develop dementia. Some of them remain stable, and some of them could actually be improved. Another story that I would like to share is about someone that could actually be articulate, always sharp, but recently he noticed that he forgets things. Maybe he takes the wrong turns, especially nowadays kat KL, there's a lot of these new roads, new U-turn and all this multi-layer of roads going on. You sometimes get confused, and that is normal. But you have to develop the management to improve or get your memory a bit on better side. So there's two forms of MCI. Next, where we like you to a bit aware of, they call it amnestic MCI, where memory problems are most prominent, which forgetting recent conversation, forgetting what you eat in the morning, or maybe forgetting what you've done last week, or to non-amnestic MCI, or more into attention, planning, and language. These two mild cognitive impairment types are having different prognosis altogether, in a way that if you have attention issue or planning issue, maybe some language or trouble organizing tasks, that is not something that we are worried so much. We are more concerned if you have amnestic MCI, where you are unable to remember very much recent conversation, very much recent appointment, because this is the majority of the one with amnestic MCI would actually progress to dementia or forgetfulness or disease itself. While the non-amnestic MCI have a very good prognosis to be better, to have improved, certain tasks can be done to improve their cognitive function or even their memory issue, and at some point it can go back to normal aging or normal memory. Next. So what are the warning signs you want to look for? Sometimes simple thing as repeated asking the same question, they're losing track of dates and times, misplacing things more often than usual. So maybe you forget things once in a while, it's quite common, and usually you found it back, you dah jumpa balik, and maybe in a week or in 2 weeks, or usually occurs when you are very much overwhelmed in the situation where maybe there's a new a child or grandchild coming in the life, or maybe a new somebody passed away, or death in the family, or traumatic situation in the family, diagnosis of cancer, where there is some triggering factor, what we call it actually stress situation in the family. So when this happen, it is quite common sometimes to lose track of time, but if it occurs persistently, continuously, and that is something that you want to watch for. They're struggling of finding words, especially if you've not been using the certain language for some time. Maybe you've not been speaking Malay for a long time, and then suddenly you forget certain words and become more and more often. You want to look into it. Trouble following conversation. You're not able to follow the flow of the stories. Sometimes reduced judgment, or you tend to more withdrawal of your hobbies and activities. This, when you see in the elderly, you want to look into why does this happen. Is it there is issue of emotion, time, or they just have difficulty in understanding the situation as it's become more complex to them. So you need to watch the pattern a few months and get a reassessment and checkup from the hospital nearby. Next. Okay, so when you talk about normal aging, it's occasionally forgets, but then you tend to remember. While mild cognitive impairment, you forget things and you are not able to recall for a long time, or maybe not at all. Normal aging, you can still be independent with daily tasks, but mild cognitive impairment, you have difficulty managing bills. Sometimes you forget cooking macam forget totally what things, ingredients that you need to put, as simple as making pancake ke, masak kari ke. You tend to forget what are the ingredients inside, or things that you've been doing all days, such as medication, tablets of medication, become a big task on you. There's also sometimes you can see in the elderly, they tend to become a bit upset when they forget. And this is something that we found very common in our population. Instead of saying that it is a bit hard on me to manage this, or a bit difficult for me to take care of the kids at the same time cooking, I might need help, our older generation tend to become angry and very not open for help. So this is one of the common issues that we find, hence makes the diagnosis of memory cognitive impairment a bit difficult, because they themselves are not able to accept that at some point they might need help and they might need some support in order to ensure healthy memory or healthy brain at the same time. Next. Okay, age-related forgetfulness, or is it signs of dementia? As the slides before, this is sourced from the National Institute of Aging in 2021. When you have age-related, you tend to make bad decisions. Sometimes, once in a while, maybe in terms of bargain, sometimes I'm not going to blame the older people entirely, because if you go to the shop, sometimes they give you like, okay, buy 2 free 4, buy 1 free 1. You tend to make bad decisions. You don't know which one is which because it takes so much time. How do you do the calculation? But then if you have dementia issue, you might make poor judgment in the sense that, okay lah, I'll buy everything. And then you tend to not aware how much money you have spent the whole day. They tend to spend more than they have, to the point that they might get their credit card being blocked because they could not remember how much money they have spent the whole day. For the age-related, they might miss some monthly payment, and then the next month you might see that this rate saying that, oh, you haven't paid your bills for your electrical bills or your internet bills. But for the one with dementia, the issue is more prominent. They probably haven't paid, and they didn't pay at all. And all these bills that come to them, they are not aware that it's something that they need to take a task at that point of time. So it is a very, the line can be very blurry. So as a carer or family members, you have to be aware where is your elderly at about. Is it they are just being forgetful, overwhelmed, or not updated with the tech, or they are very much forgetful and needs medication and treatment attention from the healthcare very, very soon. Okay, next. What can be done? As what Prof. Tan Maupin has said just now in the morning, our aging population is going to be about more than 15% by the year 2024. When we become age aging nation, a majority of our patients are aged more than 60%. It's in 60 years old. So you yourself have higher risk of developing memory issue as once you age more than 60, and actually 1 in 4 once you age more than 80 years old. So taking care of your memory very early on is very, very important. The things that we neglected in our society are the simplest thing, which is everybody knows: blood pressure, diabetics. And blood pressure, sugar control, cholesterol control is something not just about your health in terms of body, your heart or your kidney. It's also involved into your brain. Sleeps, not sleeping, insomnia, watching on YouTube until like early morning, 1 or 2 o'clock in the morning. Unfortunately, it's very common in our elderly. They tend to watch television a bit more. They tend to stare at their phones a bit more, and all this can cause chronic stress. Depression or social isolation, being alone majority of the time of the day. I mean, maybe your children are a bit busy, their grandchildren a bit busy. They have to fill their times with other things like friends, social event, gathering with your old friends. It is very, very important because depression occurs very commonly especially due to the social isolation. History of dementia in the family, and of course being sedentary lifestyle or poor in terms of diet makes them have higher risk of developing dementia. So things like keeping your brain active, learn things. It's not that once you age 60 years old, you are not allowed to learn new things. You can still learn to draw, learn to paint, learn to dance, which I encourage majority of my patients to do. Learn new language or learn a bit more on your religion will actually put you in a situation that you are motivated. You feel there's things that you still can do and you get connected to other people's. Exercise, maybe about 30 minutes a day or just simple walk can improve a lot in terms of your memory and your circulation to the brain. So things like this is something that we can manage very early and can prevent issue in terms of memory. Next. So these are things that we would do if you come to us with memory issue, memory complaint. We'll do some screening tools. So there's a history on your memory, certain blood tests, because some diseases can present with memory issue such as thyroid problem, hypothyroid or hyperthyroid, vitamin B12, cortisol issue. Sometimes electrolytes such as hyponatremia due to medication can cause memory issue. We'll do a brain imaging if needed and functional assessment to confirm whether it is a mild cognitive impairment or is it just forgetfulness. Next. And as I said just now, things that we can do early on before medication, before any treatment, is actually managing your blood sugar, your cholesterol and your blood pressure at home. This brings actually the most impact in your life and the most much change if you compare to medication. For this intervention that being done early on could reverse or even makes your memory much better. So you have a certain things like a very good lifestyle. I mean, people tends to talk about walking 30 minutes per day, to ensure that you are not obese and things like that. But actually, this is important to ensure brain health also. Have a good diet, not just Mediterranean style diet, but sometimes vegetables, increase vegetable intake, ensure bowel motion, daily bowel motion, because this can be neglected. Elderly people tends to not want to drink water, which is water is life. So you have to drink water. There's no way about it. Getting medication to move your bowel is not your life that you want to be, because you then become dependent. Stay socially active, join clubs or volunteers, community event, and good sleep. This, I think, 4 things. Manage your health, exercise, diet, and stay socially active. It's a key for healthy aging. Things like sleep, or you can do also some reading, puzzles, learning new skills would actually makes your life a little bit more interesting and better. Next. So what are the roles of the carer? We as a carer encourage daily routine very much. So majority of our elderly, once they age more than 60, 65, once they stop working, they tend to have a poor routine. They wake up anytime that they want, they go to sleep anytime that they want. Sometimes they tend to not want to care whether it's Monday or is it Saturday, because for them every day is a holiday, right? That's what one of the commonest comment that I heard from my patient, like, why is it matter? I'm not doing anything anyway. So ensuring that you have a routine, maybe morning yamcha or minum or breakfast with your friends, morning exercise, evening walks, sometimes certain things like picking up your grandchildren every other day or things like that would put some activities and routine that will ensure that you are making your days more meaningful than others. Monitor changes in terms of cognition and in terms of mood, understanding that certain situations such as death in the family, death of spouse, death of sometimes their own children, a diagnosis of terminal illness diagnosis for other people close to them, their friends, would affect their mood and their cognitive function. So all this as a role, as a carer or allied health, you have to understand this situation that cause effect in terms of their cognition and mood. They might need support, and a simple support could prevent complication in the long run. Because if they tend to be on the low mood or depression in the elderly, maybe the first few months is not that obvious, but once it occurs longer than a year or two, they become very much dependent, and it's a kind of a vicious cycle. They not want to eat, they not want to sleep, they become restless, agitated a bit, and then it cause a permanent damage to their brain also. Next. So when to seek help? When you realize that the memory issue affecting their work and relationship, when the confusion or disorientation occurs more frequently than ever, and if there is some behavioral changes, any point of time, family or carer feel that there's things that's not, sometimes you can't really pinpoint. We could use the word ngam or different, or changes that permanent, more than 3 months or 6 months, you would want to seek for help and some attention. So at least an evaluation early on would able to make sure that the steps taken to improve their cognitive function. So next, our key takeaway is mild cognitive impairment doesn't always means that you would develop dementia. So early stage, early recognition, management could actually reverse or improve their memory issue, and they can maintain independency, which what we want for ourselves and also for our elderly. We want them to be independent. We want them to be able to care for themselves so that they are able to not contribute, but they have a comfortable life. So we are not talking about longevity in terms of age. We want them to be healthy aging. They want them to be independent and have a quality life. Not just you age maybe up to 80, 90 years old, but the last 20 years you are not able to even go to the toilet yourself. It can be something that very much painful to see, more or less painful to bear. So early detection helps maintain independence. Simple things like lifestyle and medical care, medication are things that you can do, and it is the key factor to improve your healthy aging. Carers and allied health are keys in partners, and understand the situation, replace it from fear to understanding. Thank you. I think that's all my talk for today. Thank you, Prof. Arimia. Okay. Any question ke? Tak ada question kan? YouTube. Okay.
Tak ada, Prof. Thank you, Prof. Izzati, for helping us understand what mild cognitive impairment really is and how we can tell when forgetfulness might be something more serious. Moving on, I would like to introduce to our next speaker for today, Associate Professor Dr. Tan Kit Man, who is a Senior Consultant Geriatrician in the University of Malaya Medical Centre, She received her medical degree from Trinity College, University of Dublin, Ireland in 1999. Professor Tan is a Fellow of the Royal College of Physicians, Edinburgh, UK. She completed her specialist training and received her certification of satisfactory completion of specialized training in geriatric medicine from the Irish Community of Higher Medical Training, Royal College of Physicians, Ireland in 2009. She was practicing as a consultant geriatrician in Dublin, Ireland in 2012 until 2012, and Prof. Tan's special interests include stroke, atrial fibrillation, dementia, osteoporosis, hypertension in older person, and comprehensive geriatric assessment of the complex older person. Prof. Tan is also an associate professor with the Faculty of Medicine, University of Malaya. She is the trainer for the Malaysian Geriatric Medicine Specialist Training Scheme, Master of Internal Medicine Program in University of Malaya, as well as the University Malaya Medical Program, UMMP. She is a member of the Malaysian Society of Geriatric Medicine and participates as a speaker and presenter of research finding at the annual Malaysian Congress of Geriatric Medicine. Hi, Prof.
Hello, good morning.
Good morning. So please welcome Associate Professor Dr. Tan Kitman, Geriatric Consultant, with the topic, What Happened to Our Brain as We Age?
Thank you very much for the kind introduction. And thank you everybody for joining us. And my talk this morning is, what are the changes in the brain as we age? And there we go. What happens to our brain as we age? That's my talk this morning. So, what is the brain? It is a complex organ. It controls everything in our body, like thoughts, memory, emotion, touch, vision, hearing, smell, and taste, the 5 senses, and also our motor skills, how we walk, how we do things, our breathing, and our temperature. Also hunger and every process that regulates our body. So together, the brain and the spinal cord that extends from the brain make up what is called the central nervous system, or CNS. You can see from the picture on the right that the brain is connected to the spinal cord and all the nerves that go to our limbs and the rest of our body. Okay, and next slide, please. What is the brain made of? It's approximately 3 pounds or 1.36 kilograms in the average adult. It's about 60% fat, 40% carbohydrate, protein, water, and salts, and also has many, many blood vessels in it. If you look at the picture on the right, those are the many blood vessels that supply our brain tissue. There are also nerve cells, and then the ventricles full of liquid, or cerebrospinal fluid, CSF, the black liquid in the middle of the CT scan. Okay, and next slide, please. Thank you. What does the brain consist of? It has grey matter, you can see in the picture on the bottom right, that's responsible for processing and interpreting information. Then there's white matter underneath the grey matter. It's like the connections. It transmits information to the rest of the body. They all consist of neurons or nerve cells. So the top right of the slide, you will see that there's a nerve cell called the neuron, and they're myelin covering the axons so that it can transmit the signals from the body to the other side of the nerve cells. So really the brain is quite a complex organ full of nerve cells. And next slide, please. What are the names of the different parts of the brain? There's the left and right side of the brain called the cerebral hemispheres. So left and right side of the brain. Generally, the left side of the brain may control the power on the right side of our body, and the right side of the brain controls the power on the left side of our body. And most people's speech center is on the left side of the brain. So the front part is called cerebrum, got left and right hemispheres. Then there's the cerebellum at the back, and then there's the brain stem, the long thing at the back. And next slide. So lobes of the brain and what they control. If you please look at the picture on the right, there's frontal lobe, in the front, parietal lobe, temporal lobe near the ears, occipital lobe at the back. And all these different lobes have different purposes, or their jobs are different. So for example, if a person had a stroke in a particular area of the brain, it will affect the function of the person that is controlled by that part of the brain. So the frontal lobe controls personality, decision-making, movement, smell, ability to speak. And then the parietal lobe controls how we identify objects, spatial relationships, getting from one place to another, pain and touch, and understanding language. For the temporal lobe, it controls short-term memory, speech, musical rhythm, and smell. And the occipital lobe is mainly for vision. These are just the basics. There are actually many other functions that all these lobes control. So again, if a person had a stroke or traumatic brain injury that damaged a particular part of the brain, those functions will be affected. And next slide. Thank you. The cerebellum then, at the back, the blue color partner, coordinates muscle movement, maintain posture, balance, and equilibrium. So if there was a stroke there or some damage there, the person's balance will be very poor. They cannot walk straight. Then the brain stem, the long orange thing, it consists of 3 different parts. The midbrain will facilitate various functions from hearing and movement to calculating responses and environmental changes. It enables movement and coordination. Below that would be the pons. And this area has the 12 nerves of the head and neck. It will control how we move the muscles of our face, tear production, chewing, blinking, focusing vision, balance, hearing, and, as mentioned, facial expression. Then finally, at the bottom, medulla connects the brain to the spinal cord. It's essential for survival. It regulates many bodily activities like heart rhythm, breathing, blood flow and oxygen, and carbon dioxide levels. It also controls the reflex activities like sneezing, vomiting, coughing, and swallowing. So all parts of the brain are very important. Next slide. Then finally, there are even deeper structures inside the brain. A small area called hypothalamus. It regulates body temperature, hunger, thirst, memory, and emotion. Amygdala, emotions and behavior, also memory. Fight or flight, you can see on the diagram on the right. Then hippocampus for memory. It's a little seahorse-shaped thing. Learning, navigation, perception of space. Then the pineal gland for circadian rhythm, sleep-wake cycle. And finally, the pituitary gland. It's a hormone center that controls the hormones in the rest of the body. So you can imagine how complex the brain is, not only for neurotransmitters, but also controls the hormones. And next slide. How does the brain work? The brain sends and receives chemical and electrical signals throughout the body. And the different signals control different processes and parts of your body, and then the brain will interpret each. And next slide. So what happens to our brain as we age? In the early years of life, millions of new neural connections are made every second. But by age 6, our brain reaches 90% of adult size. Then unfortunately, in our 30s and 40s, our brain size starts to shrink a little bit. It's gradual, but the shrinkage is even more after age 60. And then some lobes may shrink faster than others, and it may cause a problem. For example, if the frontal lobe shrinks a lot more than others, it may cause frontotemporal dementia. If the hippocampus and temporal lobe shrinks a lot more than others, it may be related to Alzheimer's disease. But everybody will have a certain degree of shrinkage. So if you have no memory problems and you went for a brain scan for another reason, and the report says there's a bit of shrinkage, don't worry, it doesn't mean you have dementia. Everybody will have a bit of shrinkage. So you can see the picture on the right shows a large degree of shrinkage, and the picture on the left, the brain is quite a full, younger brain. And next slide then. So other changes in the brain as we age. You can see on the right, the diagram, that's how the brain cells communicate. From the cell body, it transmits through the long axon with the myelin sheaths. Then there's the neurotransmitter. It sends the signal to the next nerve cell. So other changes in the brain as we age, the cortical density, there could be thinning of the corrugated outer layer of the brain. We saw the earlier slide where there's a picture of the grey matter and the white matter. And for the white matter, the myelin sheaths of the nerve fibers shrink with reduced speed of transmission, reducing cognitive function. And in the neurotransmitter systems itself, there could be reduction of the production of the chemicals that helps the communication between one nerve cell and the other. And the next slide. Thank you. So what are the consequences of these changes? Older adults might experience memory challenges like difficulty recalling names or words, decreased attention, decreased ability to multitask. As the brain ages, neurons also begin to die, and the cells also produce a compound called amyloid beta. It is what is typically associated with Alzheimer's dementia if there's a large amount. But I think in most older adults, there's a little small amount. But if there's a large amount, they may start to develop dementia. Next slide. Thank you. So what scans can be done for the brain when investigating for dementia? In case a family member needs to go see a doctor for memory problems, the doctor may choose to organize a plain CT brain with a CT angiogram. That means it can look at the structure of the brain and blood vessels. A higher level scan would be MRI brain and MR angiogram. It can give better detail of the brain structure and blood vessels, but the MRI takes a much longer time and there are not as many MRI machines compared to CT machines. So MRI could take 45 minutes and the person is in a small scanning machine that is quite claustrophobic, but some people tolerate it very well. CT brain is in a much more open area. The machine is not so closed up and it takes only about 10 minutes. Then finally, there's also available in Malaysia PET CT brain. It shows the function of different areas of the brain, not just the structure. In other countries, there are different types of other scans as well that are available to investigate for causes of dementia. But for the moment in Malaysia, these are the three basic types of brain scans that we organize. And next slide, please. Thank you. So let's look at these series of brain scans. On the left, 10-year-old. On the right, 90-year-old. And we can see that there's a degree of shrinkage in the 90-year-old with a larger ventricles and the larger sulci, which would be the black spaces between the skull and the brain matter. Now, it doesn't mean for sure this 90-year-old person has dementia. It just shows that there's a degree of shrinkage in the brain matter. But it doesn't absolutely say the person has dementia. The person may actually have no significant memory problems. So again, don't get worried if you have a brain scan for some other reason and it's written there that there's some shrinkage. Okay, and next slide, please. Now, if there was a shrinkage in the hippocampus especially, that's where the circles are. You can see that a healthy younger person with no dementia, it's quite full, that area called hippocampus. But in Alzheimer's dementia, there could be specific shrinkage in that area, also in the parietal lobe, and in temporal lobe, And in more advanced cases of Alzheimer's, the whole brain will be quite shrunken. And in this example here, labeled Alzheimer's disease, we can see, look at the higher up part of the brain scan, that there's quite a lot of shrinkage already, and the brain matter looks like finger-like structures instead of the full structure on the left. Okay, next slide, please. And how about frontotemporal dementia? That's another type of dementia. There are several different types of dementia. The shrinkage is mostly in the front of the brain and the temporal or the side part of the brain. And it will cause like personality changes, behavioral changes, difficulty making decisions. And the next slide. Thank you. Now, sometimes, very rarely, we will find abnormal enlargement of the ventricles. Picture A and picture B, we can see how large the black areas are compared to the normal brain scan we saw earlier on. and this is called hydrocephalus. Hydrocephalus means water in the brain. And it could be either normal pressure hydrocephalus, where there's no significant blockage that can be seen, but it's to do with the drainage system. Then there's also hydrocephalus due to blockage, like a physical blockage, like a brain tumor. If this is found, the doctor will get you to see a neurologist and also a neurosurgeon to discuss whether the person is suitable for drainage of the water in case some of the problems that it caused can be reversed. So this is rare enough, but on occasion we will see it on brain scan. Hence, it's quite important for us to do a very thorough investigation when a person complains of memory problems. In general, it's usually Alzheimer's dementia, vascular dementia, frontotemporal, but occasionally we will see brain tumors and water in the brain. And the next slide, please. Thank you. This is a PET CT scan. It shows activity in different parts of the brain. And you can see on the left side, PET scan of a normal brain, it's very warm. A lot of red and yellow color, orange. That means the brain is very active. It's using up a lot of glucose it's digesting the glucose, using the glucose and making all sorts of memories and also controlling our body. Then on the right is a PET scan of Alzheimer's disease, and it shows that it's rather cold or very blue or purple, means very much less glucose is taken up for the activity of the brain. Yeah. And the next slide, please. We can also see vascular changes in the brain. Vascular means blood vessels. There can be small vessels blockage, or how you say ischemia. This can happen in people with poorly controlled diabetes and high blood pressure for many years. It can lead to diffuse areas of reduced blood supply. So if we look at the bottom left, the A and B, those grey areas, the black area is are the ventricles, but the grey areas between the black ventricles and the brain matter, those are the areas that were affected with small vessel blockage or ischemia. Then how about large vessel blockage? Because it's large vessels that lead into the small blood vessels. It can occur with atherosclerosis or plaques in the blood vessel, and the plaques can become narrower and bigger and bigger until it blocks off that blood vessel, or the plaque itself could get ruptured and then it throws off a clot further up in the brain and cause a stroke. There can also be clots from the heart thrown off to the brain from the major blood vessel. From the heart, go through major blood vessel, go all the way up in the brain. Clots from atrial fibrillation. All these can lead to stroke and vascular dementia. So the bigger picture there's big holes where the stroke areas are. This person will probably also have weakness on the opposite side of the body, and apart from symptoms of dementia or reduced cognition. So the black areas would be an old stroke on the right-hand side of the picture, the top picture. And then on the left-hand side of that top picture, it might be a more recent stroke at the bottom. The top picture, but at the bottom where the two arrows are. That's a more recent stroke, but on the right side of that big picture is an old stroke. Okay, great. And the next slide, please. On MRI, we can also see the severity of these small blocked blood vessel disease. From the left is mild, all the way to the right is severe. MRI scans look different from CT scans. That's why it looks white here. But on CT scan, it looked more grey. Your doctor will know how to interpret it after ordering the test. And next slide, please. Brain tumor is a very, very rare finding. On the odd occasion, we order it for memory problems, and then suddenly we find a brain tumor. Sometimes the brain tumor is not the cause of the memory problem, and we just found it because we were scanning the brain. But sometimes it is the cause of a memory problem. If the memory problem is gradual, slowly worsening over months and years, it's less likely to be brain tumor or water in the brain, that sort of thing. But if it's more acute, means over a short period of time, the doctor will have to look for causes, like including infection, Rarely also we will find an abscess in the brain if they had a very severe infection in body and it shoots off the bacteria to the brain. But these two pictures show a brain tumor, a rare finding. So if the doctor wants to investigate somebody for memory problem, if they offer a brain scan, there are many reasons to take up the offer to do a brain scan instead of guessing what could be the cause of the memory problem. Next slide, please. Okay, so that's my last slide. In summary, as we age, there will be a degree of shrinkage of our brain and problems with blood vessels and circulation changes. Many older people will have these changes, but they do not cause a significant problem. So don't worry if you had a brain scan, there are all these small changes. Don't worry yet. Or don't worry, unless you have some problems. So however, in some older persons, these changes can cause problems with cognition and thinking and also physical abilities. So do get a checkup with your doctor if you are concerned. So thank you very much for tuning in this morning. We still have many, many more talks and hopefully you will enjoy the morning. Thank you.
Thank you, Prof. Tan, for that eye-opening session. It's fascinating to learn what's happening inside our brain as we grow older.
Okay, thank you.
Next, I would like to introduce to our next speaker for today, Ms. Nur Hafida binti Muhammad Daud, who is an experienced occupational therapy from the Department of Rehabilitation Medicine, University Malaya Medical Center. She has been serving at UMMC for 12 years with extensive experience in neuromedical rehabilitation, brain injury rehab, psychiatric and geriatric therapy. She is also actively involved in various professional initiatives including the International Day of Older Person 2022 until current, the Cognitive Stimulation Therapy Workshop, and the Quality Improvement Project on Functional Daily Activities. Ms. Nur Hafida is passionate about geriatric care and dementia rehabilitation and has also been an invited speaker for nursing and medical student lectures on occupational therapy in geriatric and dementia care. Welcome, Ms. Nur Hafida. Now, let's welcome Ms. Nur Hafida binti Muhammad Daud, occupational therapy, with her talk on simple habit for a healthy brain.
Okay, Assalamualaikum dan selamat pagi. Seperti mana telah dikenalkan, nama saya Nur Hafida binti Muhammad Daud, Occupational Therapy from PPUM. So, topik yang diberikan kepada saya ni, Simple Habit for a Healthy Brain. So, okay. For the introductions, okay, I would like to give a brief introduction for cognitions, a complex system of thought that is made up of how you think and process the information. So inside the cognition, we have a few skills that need to be achieved in order to maintain the cognitive level, which is executive functions, judgment, insight, reasoning, problem solving, memory, either it's short or long term, also arousal, attention and concentration. Okay, now when we getting older, of course there are some impairment that we can notice. For the cognitive impairment is when you have problem in remembering things, concentrating, making decision and also problem solving. So the cognitive impairment is a symptom, but it's not an illness that can caused by many conditions. So cognitive impairment can go from mild to severe. So for mild cognitive impairment, people may begin to notice changes in cognitive function, but they are still able to do their daily activity independently. While for the severe cognitive impairment, that leads to losing the ability to understand the meaning or the importance of something, and also their ability to talk and write, resulting them in inability to live independently. Okay, so as an OT, okay, what our roles? Okay, for OT in geriatric rehab, we are helping elderly people to do all the activity of daily living that become difficult to them or impossible for them to do because of their age-related changes, disorder and disabilities. So we also provide help with the social and leisure activity depend on patient capability and interest. Okay, so when we have cognitive impairment, the first thing first we can do is cognitive training. What is cognitive training? Cognitive training is a focus on the tasks that target specific cognitive function such as memory, attention and problem solving. It can be conducted on the computer or delivered in person. Either way is individually or in a group. Okay, so cognitive training also can be referred as brain training or retraining. So it's involve the guided practice. It must be structured and usually standardized tasks. Okay, so what are the activity we do with the patients? Okay, this is suggestion lah yang kita boleh buat dekat rumah, yang easily task yang kita boleh buat harian. The first one is reality orientation. This one memang simple punya activity, tapi orang selalu tinggalkan sebab dia bagi mereka is tu benda tu dah tak penting lah. Okay, so what is reality orientation? Is presenting, orientating memory information berkaitan dengan masa, tempat dan person. So selalunya it's provide understanding to their surrounding which will turn to improve their self-esteem and self-control. Okay, so macam mana kita nak buat reality orientation ni? Okay, dia boleh buat semasa mereka kalau kat rumah lah kan, sambil baca newspaper, tengok TV, kita boleh tanyalah hari ni hari apa, tak sekarang bulan berapa. So daripada situ kita tahulah sama ada mereka masih lagi ingat dan tahu masa dan tarikh pada ketika itu. So sometimes kita boleh also gunakan kalender, jam atau penggambar untuk mereka jawab soalan-soalan itulah. Okay, seterusnya aktiviti kedua adalah aktiviti of reminiscent therapy. Okay, so reminiscent therapy ni actually kita mengimbau kenangan lama. Maksudnya discussion itu kita jalankan dengan bertanyakan kepada mereka benda-benda lama lah. Contohnya masa diorang muda dulu apa diorang buat, diorang kerja apa. Okay, so daripada situ kita tahu kalau mereka masih dapat explain, maksudnya diorang punya kognitif still okay. So, contohnya medium yang kita boleh gunakan, contoh yang saya bagi kat situ adalah foto album. Selalunya dekat rumah kita ada kan gambar-gambar lama. So daripada gambar tu kita tunjuk dan kita tanya, okay, gambar ni dia ambil bila, atas masa tu ada event apa. So daripada situ kita akan galakkan mereka mengimbau balik lah diorang punya memory pada ketika dan zaman itu. Selain daripada itu, kita boleh guna art form jugalah, maksudnya menggunakan medium mewarna, melukis, ataupun menggunakan historical item, barang-barang berharga mereka. Dan juga yang terakhir tu life story. Life story maksudnya kenangan lama. Dulu mungkin mereka hidup di zaman sebelum merdeka, macam mana cerita tu bagi kita mungkin dah banyak kali dengar, tapi it's good because they need to refresh back lah dia orang punya memory. Okay, seterusnya adalah card, boards game dan electronic games. Ini memang senang untuk kita dapat. Okay, kenapa kita suggest buat ini? Sebab bila kita main all those game, kita akan memberi peluang kepada player ataupun kita yang bermain tu untuk memikirkan strategi untuk bermain permainan tersebut, menggalakkan secara berfikir dan juga macam mana dia nak selesaikan masalah tersebut. So contoh-contoh game yang ada dan selalu kita jumpa seperti chess, Scrabble, mahjong dan lain-lain lah. So kenapa kita galakkan? Salah satunya sebab game ni murah dan mudah didapati di mana-mana, dan juga kalau kita main ramai, benda tu akan jadi seronok. So and also the way to exercise their memory and strategy skill. Selain daripada tu, sekarang ni kan dah ada gadget, dah ada internet. So bukan setakat game biasa, kita boleh juga carian dekat internet. Banyak je tersedia game-game yang boleh membantu kognitif pesakit. And ada proven yang mengatakan bila kita bagi main game yang elektronik yang ada strategi dan mereka perlu berfikir untuk menyelesaikan masalah, dia memberi benefit lah kepada attention, short term memory dan also reaction time kepada mereka. Okay, dan seterusnya adalah puzzle. Okay, puzzle ni saya tahu mesti semua orang tahu. Okay, sebab puzzle ni adalah benda yang common, dan kadang-kadang ada juga bila kita bagi suggestion, mereka akan cakap apa tu, mak saya tak nak main sebab dia rasa kanak-kanak. Tapi kena tahu kenapa kita main puzzle, because puzzle ni memang diciptakan untuk memberi cabaran kepada daya pemikiran kita. Kenapa? Sebab bila kita main puzzle tu, kita perlu berfikir how kita nak solvekan that problem, dan juga sequencing tersebut lah. Okay, so puzzle ni benda yang kita senang nak jumpa. Dan satu lagi, cara nak attract lah. Sebab saya kan bila kata dekat rumah mak saya tak nak main sebab benda tu senang. So attract ni sebab bila kita jumpa yang macam puzzle ni selalu main dengan cucu. So mungkin lepas ni boleh gunakan cucu untuk ajak atuk dan nenek bermain bersama. Okay, so the next one is domestic activity ataupun cooking. Mungkin akan stereotype orang akan ingat bila kita sebut cooking ni the whole meal. No, actually bila kita buat cooking is improve self-esteem as a result of increased concentration, coordination and confidence. It's also promote positive moods and self-confidence in order to promote exchange of food and ideas. Okay, tak semestinya, sebab kita tahu banyak je saya jumpa dia tanya, makcik masak lagi tak? Tak, sebabnya anak tak bagi, bahaya katanya. Tapi kat sini saya bagi kenapa, maksudnya penglibatan mereka sahaja, bukannya dia orang masak the whole meal. Dia masa kita masak tu, mereka berada di dapur untuk membantu kita lah. Contohnya bagi simple task, maksudnya asingkan sayur ke, kopek bawang ke, benda-benda yang tidak safe lah untuk mereka buat. Sebabnya bila diorang bersama, kita buat memasak tu, kita akan menggalakkan diorang berkomunikasi, kita tanya resepi. So diorang akan flashback, ingat balik, resepi ni nak letak bawang ke, tak nak letak bawang ke. So it help them to more focus and also regain their own memory lah. Okay, so the next one, social activity. Okay, the social activity ni maksudnya diorang interact dengan orang luar, sama dalam kumpulan lah, sama ada ahli keluarga ataupun kenalan-kenalan rapat. Because engaging in social activity ni like doing volunteer, phone call, spending time akan stimulate conversation and social interaction. Because bila ada kat berkumpul ramai-ramai berbual tu akan orang kata apa, bagi dia during topik yang conversation tu, of course dia orang akan berfikir topik ni perbincangan. So sometimes ianya membantu juga untuk memberikan mood yang gembira, sebab ramai dia tak rasa bosan, dia rasa dia diberi perhatian. So it will help in dia punya kognitif. Okay, so the next one is music activity. Okay, as we know, music assists in controlling factor that contribute to elevate stress level, maintaining stress level below an individual threshold, and reduce the dysfunctional agitations behavior. Okay, activity yang kita boleh buat is listening to the music, sing along the music, moving to the beats of music, also playing the instrument. Okay, kita tahu tak semua orang suka muzik dan tak semua orang suka menyanyi. Tapi bila ada muzik, bila diorang contohlah kita pasang lagu lama-lama dan secara tak langsung diorang akan lagu ni lagu diorang akan ingatlah penyanyi siapa, and they try to ingat lirik lagu tu, macam tu. So during bila dengar tu akan mententeramkan dan memberikan perasaan yang gembira lah. Okay, the next one the memory aids. Okay, this one is kita provide external support in the form of compensatory memory aids. It can help to reduce demand on impact aspect of memory, provide cognitive support, reduce anxiety, and even promote social engagement. Okay, for example, we use sticky notes, calendar, diary, pillbox, alarm, and also Google Calendar. So this one memang membantu. Okay, contohnya kalau kita dah rasa kita starting to have lupa-lupa kan, so saya nasihatkan adakan satu buku untuk tulis all. Contohnya kalau kita banyak appointment, kita ada tugasan, kita jadikan satu buku untuk catat everything yang kita perlu buat. Kerana bila ada catatan tu, kita dah tulis semua all apa yang kita perlu buat tu. So nanti bila kita macam hari ni sepatutnya ada something, tapi apa, so kita just buka kita punya buku notes tu, kita dah tahu hari ni ada meeting, hari ni akan ada appointment doktor. So that bila kita keep our daily life tu on track, kita akan reduce kita punya anxiety, kita punya frustration. So ianya sangat membantu. Selain daripada tu, kalau itu buku tu untuk orang yang selesa manual lah, ada juga sekarang ni kita boleh dapat online Google Calendar, ataupun sekarang gadget kita pun kebanyakan dah ada notes yang kita boleh tulis. So you boleh choose either you nak guna manually, tulis buku, guna sticky note, ataupun you guna you punya gadget lah. Okay, ini memang bagi saya is cadangan yang kita boleh imply, tak kisahlah muda ke tua ke, is good to help our daily life. Okay, so this is the last one is environmental adaptation. Ini suggestion yang saya selalu bagi dekat patient, which is kita adapt our environment to be more organised, a place for everything and everything in its place. Okay, it encourage the development of habits and routines so that items are placed in specific locations and always placed back there after use. Okay, contohnya kunci kunci holder, tempat letak kunci tu kan, so kita letak on satu tempat, so all the kunci kita letak dekat tempat yang sama. Kita jadikan ianya rutin dan habit. So lepas ni, let's say kalau macam nak cari kunci, kita tahu dekat situ kunci belakang, contohnya belakang pintu ada tempat kunci. So kalau you nak cari kunci, pergi je dekat situ, takkan ada confuse, you pun takkan tercari-carilah, dan mengurangkan risiko untuk you misplace. Okay, ataupun yang kedua, benda lain yang selalu hilang, spek mata, wallet, phone, ataupun remote control, everything make a routine, letak tempat yang sama, every time nak use kita tahu dekat situ, after kita guna kita letak kembali. So benda tu akan kita ingatlah. Ataupun contoh yang ketiga itu adalah tray untuk kita letak sebarang dokumen ataupun surat menyurat yang penting untuk kita selesaikan. So senang untuk menjadi rujukan kita. So kita takkan bersepah-sepah, so kita pun takkan rasa anxious cari barang tak jumpa, takkan menambah stres kita lah, sebab kita tahu semua dah ada rutin, semua dah diletakkan di tempat yang sepatutnya. So memudahkan urusan kita seharian. Okay, that's all. Thank you.
Thank you, Miss Nur Hafida. Those tips were really practical and a great reminder that small habit can make a big difference in keeping our brain health. And now it's time for a short tea break. Grab a cup of coffee or tea, everyone. Stretch a little and relax. We will be back at 10:25 a.m. for more great sharing session, and so don't go too far. While waiting for the next session, don't forget to like our UMMC YouTube channel and share our webinar for today so that more people can benefit from our talk today. Okay, see you back on 10:25 a.m. Thank you.
This is basically my
Welcome back. Up next, I would like to introduce to our next speaker for today, Dr. Surina binti Zamanhuri is a medical lecturer and geriatric psychiatrist with a deep commitment to improving the mental health and quality of life of older adults. Clinical expertise covers dementia with behavioral and psychological symptoms, BPSD, late life depression, anxiety, insomnia, and functional disorder in the elderly. Work also extends to supporting families and caregivers, addressing the significant burden of care in dementia, and advocating for greater awareness of caregiver needs. In the academic role, responsibilities integrate teaching, mentorship, and research to strengthen the field of geriatric psychiatry. Actively involved in postgraduate training, with particular interest in structured posting mentorship model and the development of evidence-based approach to education in psychiatry. Research interests include apathy, depression, caregiver burden, and their impact on dementia outcomes, as well as broader theme of functional neurological disorder and late life mental health challenges. Passionate about bridging clinical practice with academic development, with dedication to advancing knowledge and services that support both patients and caregivers. However, Dr. Surina unable to be with us, but she has prepared a pre-recorded video that explaining on feeling low or losing memory, know the difference.
I'm sorry that I have to pre-record my presentations today because I'm at outstations, and my topic today is feeling low or losing memory and know the difference. Okay, this is basically my outline for today that we are discussing there. Okay, as introductions, as we get older, it's not uncommon to feel a little bit down or forget things once in a while. But sometimes those senior moments or low mood can be a sign of something more. So I feel that some or quite a number of my elderly patients, sometimes they feel that a little bit down. I'm not happy a little bit, but it's not so much. But I also forget whether this is something that normal aging or depression, or could be is early memory decline. Memory decline, basically, they forget things. Sometimes my patient come to me, or whether I have nyanyo or not, doctor. So this is the thing that we need to, the reasons of the topic today. Okay, late life depressions. What is late life depressions? Late life depressions is defined as the major depression, which is depressions occurring in adult age of 60 and older. And it's also included that those that having depression at the younger age and continuous until the age of 60 and above. And compared to the late onset depression, the term late onset meaning that they have first episode and the first onset of depressions happen after age of 60. Okay, meaning that before umur 60 they are okay. After umur 60 they started having the depressions. Okay, why we need to know this? The reason kenapa kita kena tahu this because of if we need to compare those yang having the depressions at the late onset, they have a worse prognosis. Meaning the outcome is not so good, and they end up with the chronic cause and higher relapse. Meaning senang berulang. And also the higher rate with the medical comorbidity, dia akan ada impact of other physical health also, and associated with the cognitive impairment and mortality. Cognitive impairment is basically their memory lah. Okay, how common is depressions in elderly? Okay, according to WHO, unipolar depressions in elderly about 7% in older populations, and about 5.7 years live in disability among those yang 60 and above. And their median prevalence of depressions about 10.3. And quite common, higher depressions ni higher level for people ada physical illness. For example, they have maybe stroke, some arthritis, some other medical problems lah. And then about 20 to 40% with the Parkinson disease, and those that having dementia about 20 to 50% of them develop depressions, and about 1/3 for people that develop depression after stroke. And it is 3 times common for people that stay at the residential care facilities. And compared to men and women, this is more common in women. Okay, this is the Malaysia survey lah, National Mobility Survey. This is 2018, and they said that among 10 people who are depressed, among 10 people who are elderly, there are one depressed elderly, and it's more common for those that divorcee and at the rural area. And this survey also supported by another study. They said that this is another local study said that in Klang Valley, about 20.9% among Malay develop depressions in the Klang Valley. However, at the rural area, about 30.1% of them, of Malay people, develop the depressions in elderly. Okay, what's the difference? Why we need to talk about the depressions in elderly? What's the difference between elderly and young onset? Okay, usually in people with the older patients, they always have different complaint and presentation. They always have different. It's not like when people with when I have patients, young patients, sometimes they come to you, doctor, I'm sad, I'm not happy with things, I'm not happy with this. But compared in elderly, they're not straight away telling you that I'm not happy. They less common complain about their mood symptom, unhappiness. Sometimes they complain with other things. This is I will discuss further later in the next slide. And majority of them say that okay, in elderly they come to you, they say that I'm tired, doctor, but end up they will minimizing the I'm tired because maybe I'm old, maybe because of my sleep is not good. So this is their common complaint in older people when they come to see a doctor. They not straight away cakap saya sedih hari ni, doktor. Dia always cakap saya sakit-sakit, tapi dah check doktor tak ada apa-apa. So this is the thing yang always happen. And after they check everything, they say that somatic symptom, right? They're having non-specific pain. After kita check semua, tak jumpa reason. Nak kata arthritis tak arthritis. Nak katakan ada isu ada ulcer ke, ada apa ke, kita tak jumpa. Tapi this is always the reason they always complain lah. Okay, so typically, when elderly patients come to you, they always deny being depressed. Tak lah doktor, saya okay je, apa lagi nak depressed, anak-anak dah besar, tak ada apa nak fikir lagi. They always minimize that. So sometimes for a doctor yang we're not used to see that the elderly patient, we may think that okay lah kot, betul lah kot dia cakap kan. And then when they have symptom, they say okay je doktor, saya tak boleh tidur, tapi okay lah, boleh lah tidur sejam 2. Tapi they feel disturbed of that because bila dia tak boleh tidur, siang dia rasa penat. So another thing that they feel recognize that in dunia ni, maksudnya dia orang tak nak keluar, dia rasa macam nak duduk rumah je. And then dia akan explain, dah tua doktor, nak pergi mana sangat, nak duduk rumah. Kita pula as doktor yang jarang tengok, betul lah kot, ada ni tak nak keluar, dia penat. And then when at the point that bila kita cakap to the patients, actually you have depression, ciri-ciri ni ada. Ya ke doktor? Tak adalah, saya nak depressed buat apa? So this is always the way of they presented. And again, they always come with the somatic symptom, pain, unspecific pain. Sebab kita kalau pain, kita ada sebab kan, mungkin ada sakit lutut ke, sakit badan ke, tapi bila kita cari tak ada sebab yang boleh menyebabkan kita kata dia having depression. Okay, when talk about the depression, there ada cluster of symptom. There ada a few cluster of symptom. This is one of the cluster symptom yang quite common lah. Maksudnya changes in the mood. So changes of the mood ni, dia banyak lah symptom dia. So example, rasa sedih, tak ada motivasi, senang menangis, feeling down, rasa tak ada ni, hopelessness, irritable. So kadang-kadang dia cepat risau. Ada juga yang ada panic attack. This is the cluster of the symptom. Tapi macam yang saya cakap awal-awal tadi, dia tak selalu datang dengan the mood symptom. Kadang-kadang ada lah, mungkin dia kata saya mungkin sedih lah doktor, tapi okey je. So kita pula confused, sedih ke tak makcik ni? So tapi this is some of the cluster of symptom yang under depression. So it's good for us to know lah. Okay, and another cluster of symptom yang can happen in the depression, changes a perception, the way they look at things. Okay, dia ada withdrawal, withdrawal ni maksudnya tak nak join orang ajak keluar pun tak nak, ajak pergi kenduri pun tak nak, family datang pun tak apalah, sembanglah, dia nak rehat dalam bilik. So dia rasa macam keadaan sekarang dah berumur, tak ada harapan, tak ada orang boleh tolong, tak mengharapkan sesuatu. Dan bila jadi apa-apa saya blame, mungkin sebab dia menyusahkan anak-anak, tak patut dia buat macam ni kan. Okay, dia bila bawa keluar pun pergi jumpa saudara mara pun dia rasa macam dia tak boleh nak rasa pleasure, tak boleh rasa seronok. And then start to believe that I ni menyusahkan orang, I ada sakit yang serius, delusions kan. Sometimes bila dah severe sangat depression tu, dia ada hallucination juga. Hallucination maksudnya boleh dengar atau lihat sesuatu yang orang lain tak boleh tengok. And then rasa macam tak berguna. And then rasa takut tanpa sebab. Kadang-kadang ada juga yang cakap, saya rasa risau doktor, tapi saya tak tahu saya risau pasal apa. Kadang risau pasal anak, risau pasal cucu, risau pasal suami, risau pasal saya. So macam-macam kerisauan yang kadang-kadang kita pun tak boleh identify kan. Bila kita tanya dia pun tak boleh identify, kita pun tak tahu apa yang dia risaukan. Okay, changes in behaviour. Ini another cluster of symptom yang can happen in people with depressed. So dia ada rasa macam changes appetite, weight loss. Ini dia akan cakap lah, dah tua doktor, makan bukannya banyak doktor. Biasalah makan sikit, memanglah kurus sikit. Tidur pun mungkin terganggu, tapi orang tua kan doktor kan. Kita pun yelah dah tua kan, orang dah tua ni mungkin tidur sikit, tapi it's not less. Memang physiologically bila kita berumur, duration of sleep tu memang boleh jadi kurang, tapi tak semestinya semua orang kan. Jadi kita kena faham dia punya fisiologi dan macam mana yang dekat patient tu, dia very individualized yang kita kena assess. Yang kalau sebenarnya dia rasa sleep tu disturb tapi dia macam susah nak mengaku, so kita kena korek lebih sikit pasal sleep tu. So bila pergerakan ni pun jadi lebih slow, cepat penat. Kadang-kadang dia akan cakap mungkin dah tua ni eloklah tak menyusahkan orang, harap cepat meninggal, cepat mati macam tu kan. So ini antara simptom fizikal yang boleh berlaku dalam older person. Okay. So tadi saya dah explain banyak simptom-simptom of the depression yang boleh berlaku dalam people with elderly kan. So antara kalau kita nak katakanlah keyword, bukanlah keyword, red flags lah to suspect kan, mungkin this person ada depressions. So cognitive deficit, this is quite common. Sebab kadang-kadang patient my experience with older person, kadang-kadang dia just datang to you cakap, saya lupa doktor, tak ada masalah lain, saya tak tahu kenapa saya lupa. Sekarang saya nganyut doktor. Itu yang diorang selalu datang to see you lah. So this cognitive deficit is quite common sebenarnya in elderly. Dia datang cakap memory cepat lupa, tapi bila kita check tak ada ke arah dementia. So possible in this situation dia actually depressed. Okay. So again, bila dia orang depressed in older person, dia always ada somatic pain. Somatic ni maksud badan, sakit-sakit badan. Yang kita tak tahu sebab apa kan. Kita cari punca tak jumpa. And then common juga dia ada anxiety. And then when we depressed, we tak boleh fokus. So that's why dia ada poor concentrations. Psychomotor retardation is basically dia gerak lagi slow. Kadang dia boleh try to rationalize kan. Dia kata, okay lah doktor, dah berumur, memanglah jalan slow sikit. Tapi tak, berumur memang slow. Tapi bila dia depressed, dia orang lagi slow. Okay. And then dia akan always feel like, saya ada sakit yang serius kot, poor perceived health kan. Mungkin saya ada sakit yang lagi teruk ke, saya ada cancer ke saya ada ni kan. And then sometimes when they depressed, they also sebelum ni tak ada constipation, bowel open okay, tiba-tiba start ada problem dengan constipation. Okay. Apa sebenarnya challenges in elderly ni? So I believe ini memang quite common lah sebenarnya, challenges dalam nak diagnose depression in elderly ni. Sebab ni yang pertama, sebab kebanyakan elderly ni they not presented with typical symptom of depression compare dan younger kan. Macam saya kata tadi, orang yang younger, maksudnya umur 20, 30, 40 ni kadang-kadang dia datang to you, doctor, I'm sad dah for some time, I'm not happy with this. Macam elderly, macam saya kata tadi, dia tak datang dengan typical symptom, dia datang dengan simptom yang dia tiba-tiba macam restless, agitated, sub pain, yang kita tak tahu kenapa. Kadang-kadang perut rasa tak selesa, diarrhea, constipation, and then hypochondriasis ni dia rasa believe dia ada sakit yang serius. Ini yang common in elderly. Dia tak macam typical symptom yang depression yang mood tu. Dia banyak macam physical symptom. And then kadang-kadang yang make thing lagi challenges, diagnostic criteria tu boleh overlap dengan simptom yang macam dementia. Macam kata tadi kan, bila dia depressed, dia ada lupa. So kita ingatkan dia orang datang kat kita nak check doktor, kod saya ada nganyuk. Itu yang kadang-kadang overlapping yang changes. And then prominent somatic complaint, again banyak yang jurnal pun dia akan quote ni, really dia akan cakap banyak somatic complaint. And prominent cognitive impairment. Cognitive, when we talk about cognitive ni, sebenarnya cognitive ni about ingatan, memory. Ya, okay. And juga diorang akan banyak juga presented dengan rasa anxiety, gelisah. Gelisah itu rasa risau, akan fikir berulang-ulang kali apa ni, kalau macam kalau jadi macam ni macam mana, nak pergi macam mana. So dia akan fikir yang perkara yang berulang-ulang. Okey, pseudodementia. Perkataan pseudo tu maksudnya tipu, bukannya real. Dementia is nyanyuk. So maksudnya perkataan dekat sini pseudodementia ni dia macam simptom nyanyuk tapi dia bukan nyanyuk. Ini quite common sebenarnya dalam people yang depression in elderly. Dia datang kat kita, dia kata dia lupa, tapi bila kita check dia tak ada simptom-simptom, tanda-tanda, dan bila kita buat test dia bukan simptom yang ke arah nyanyuk. So tapi itu yang prominent simptom. Maksudnya dia datang itu yang paling prominent simptom yang lupa. So kita kena ingat benda ni antara simptom yang overlap. Depression pun boleh dapat lupa-lupa, and dementia yang nyanyuk pun sendiri memang boleh ada lupa-lupa. Tapi sebenarnya diorang bukan nyanyuk, tapi diorang sebenarnya depressed. Dan usually kalau dalam kes yang macam ini, bila kita dapat detect this is sebenarnya pseudodementia, masalah ingatan yang dikata lupa-lupa tu akan almost fully recover ataupun kadang-kadang fully recover bila kita treat the depression tu. Bila kita bagi anti-depression, kita treat depression tu, memang dia pun okey balik. Banyak juga jadi kat patient saya kan. Dia kata macam dia lupa. Selalu tak boleh nak ni, tak boleh nak fokus, tak boleh nak ni. Tapi bila kita rawat dia punya depression tu, dia dah back to normal. So dia kata, oh doktor saya dah okey. So quite common untuk older person ya. Okay. Insomnia. Insomnia ni susah nak tidur. So macam mana insomnia ni sebenarnya? Ada kaitan tak insomnia ni sebenarnya dengan depression in elderly? Yes, sebenarnya common. Kadang this antara kluster yang simptom yang patients yang older person yang datang to see me. Dia kadang-kadang datang jumpa saya sama ada lupa, susah nak tidur ataupun non-specific pain. Ini yang common ni kan. Kalau kita tahu depression, sedih, rasa low mood semua. Tapi really this is symptom yang quite common. Insomnia memang common. Dia kata macam susah sikit nak tidur doktor. Tapi mungkin sebab saya dah tua kan doktor kan. Kadang-kadang dia nak kita macam katakan ya kan. Tapi bila kita korek-korek sebenarnya ada benda perkara yang merunsingkan mereka dan menyebabkan mereka tak boleh tidur. Okay. So dia memang ada study lah yang mengatakan insomnia ni is also a risk factor untuk new depressions and depressions yang berulang, especially dalam older adult. So memang well known benda ni. Untuk kita yang dah biasa tengok, kita tahu tak boleh nak sorok-sorok, nak try nak hide, I'm not depressed. Tapi bila kita korek-korek, sebenarnya dia orang depressed. Okay. So the treatment yang direkomend by expert, dia kata kalau boleh kita avoid ataupun minimiskan. Benzodiazepine ni basically ubat tidur. Bukan kita tak nak bagi, memanglah kata tak boleh tidur kan, kita bagilah ubat tidur. Tapi masalahnya ubat tidur ni dia ada consequences dia. Maksudnya kalau long term, satu boleh membuatkan kita dependent, perlukan dos yang makin tinggi. Tapi bila berumur ni yang paling saya risau, bila kita bagi ubat tidur ni, dia akan ganggu dia punya alertness. Kadang dia confuse sikit, masalah respiratory, and bila fall. Tahulah kan bila kita dah berumur kadang-kadang ni, bila kita fall ni tulang kita tak sekuat bila masa muda. So senang risk of fracture. Itu yang kita risau sebenarnya. So usually kalau kita tengok dia insomnia tu disebabkan depression, kita rawatlah depression tu dulu. Okay? Okay, risk factor. Kalau kita cakap pasal depression, mesti ada siapalah yang paling berisiko kan untuk dapat depression in elderly ni. So dia memang adalah dia mention kan, kalau macam people yang ada penyakit kronik, ataupun orang yang ada chronic pain, kadang backache lah, yang ada backache yang lama, ataupun sakit lutut. This is antara people yang ada risk factor lah untuk develop depression. And then ada banyak medical problem, penyakit medical lah, penyakit fizikal macam darah tinggi, kecil manis, kolesterol, stroke. So benda-benda macam ni pun boleh menjadikan satu risk factor lah. Okay, untuk develop depression. Okay, alkohol, dadah also boleh. So ada family history juga masalah depression. Tapi kita kata kalau yang onset yang elderly, umur 60 ke atas, sejarah keluarga ni not that significant. Dia lebih kepada significant kepada orang yang onset yang lebih early. And then some medication, nanti saya akan go through. Some medication also boleh menyebabkan simptom yang nampak macam depression. Okay, reduce functionality. Kadang-kadang kita tahu some of elderly, they used to be very independent. Tiba-tiba mungkin ada stroke, kena bergantung pada keluarga. So, dia reduce function. So, ini boleh menyebabkan salah satu faktor yang boleh menyebabkan mereka merasa depressed. Okay. So, masalah pendengaran, masalah ingatan juga, dia rasa dah makin kurang ingatan. Kadang-kadang dia mungkin memang dia ada dementia, early phase of dementia. Dia dah tahu, okay, nanti saya dapat dementia ni, saya akan bergantung. So, dia start boleh ada kemurungan dah masa tu. Significant loss. So, we know kan, when we get older, kadang-kadang kita kehilangan spouse, kita kehilangan keluarga, kadang-kadang ada yang kehilangan anak. So bila kita kehilangan keluarga ni, major loss ni boleh affect kita as elderly lah kan. So itu boleh menyebabkan kita isolated daripada orang. So loneliness tu sendiri, bila kita isolated, kadang-kadang kita tak ada aktiviti, kita jadi alone, jadi loneliness. Loneliness tu sendiri adalah risk factor untuk develop depression in elderly. Okay, so support pun tak ada. Bukan kata anak-anak tak kisah, tapi because of anak-anak, dia orang ada komitmen dia orang sendiri, mungkin balik sebulan sekali. So support tu kurang, so itu boleh menjadi risiko kemurungan di kalangan elderly. Okay, kalau compare dari segi gender, dia lebih common in perempuan, female more than male. Okay, macam saya kata tadi. Apakah penyebab? Ini memang soalan common lah juga. Saya ditanya oleh pesakit saya dan juga keluarga mereka. Apa sebab ya doktor dapat kemurungan ni? Macam kita kata genetic factor. Genetic factor is common sebenarnya. Tapi kalau ikutkan kita punya evidence, genetic factor ni tak berapa signifikan kalau kita katakan yang late onset depression ni. Kalau compare dengan yang onset umur 20 awal tu, dia lebih berkaitan dengan genetik lah, maksudnya sejarah keluarga. Okay, so itu yang lebih common lah. Okay, kalau nak katakan environment factor, tak banyak bukti yang mengatakan dia ada kaitan yang kuat lah. Tapi kadang-kadang disebabkan oleh kehilangan tu pun boleh menjadikan salah satu faktor lah. Okay, psychological factor, macam saya kata tadi, loneliness, isolation. Loneliness and isolation ni, macam isolation mungkin disebabkan dia tak boleh nak bergerak sangat, sebab mungkin ada masalah arthritis ke, stroke ke. So bila dia dah isolated, kadang-kadang dia tak ada connection dengan luar, dia jadi loneliness. Ini memang faktor risiko lah untuk menyebabkan depression, macam saya cakap sebelum ni. Okay, so kadang-kadang reduce sense of purpose. Ini yang kadang-kadang dia dah biasa bekerja, hold of good position before, tiba-tiba pencen, semua orang dah tak kenal dia, dah tak ada aktiviti. So ini pun boleh menjadikan salah satu faktor kemurungan. So that's why saya selalu encourage pada pesakit saya, dah bersara buat aktiviti, jangan duduk rumah. Saya memang tak encourage of my patient bersara duduk rumah. So you have to involve with activity, anything that yang suit you. Okay, sometimes fear of dying. Memanglah kita kata semua orang akan mati, tapi sometimes they feel that okay, what going to happen to me kan? Macam kita tengok news sekarang ni, kadang-kadang ada jumpa found dead dekat rumah after 2 weeks macam tu. So this is a fear, kadang-kadang is legit tau. Dia orang rasa macam is I'm going to be like that, I'm alone kan? So there is some fear yang kadang-kadang dia orang susah nak discuss. Macam orang akan cakap memanglah semua orang akan mati, tapi how kita mati tu, itu yang membuatkan mereka risau kan? So organic factor, kadang-kadang dia sihat sebelum tu, tapi unfortunately dapat stroke. So stroke tu sendiri maksudnya ada blockage blood vessel dekat otak, dan eventually boleh menyebabkan dapat depression. Okay, so some of personality dia personality pun masa muda dia jenis yang everything nak perfect, obsessed, dia kena jadi macam ni. So bila dia berumur tu, kadang-kadang benda tak follow what they used to like, benda tu boleh juga mendatangkan kemurungan lah kepada mereka. Okay, this is I just go through cepat-cepat lah yang ni kan. Ada causes lain daripada yang saya mention tadi. Ada penyakit-penyakit lain yang boleh menyebabkan kemurungan dalam elderly. So kadang-kadang bila first time datang umur 60 ke atas, saya akan check ni, ada tak benda-benda ini yang boleh menyumbangkan kepada depression. Kalau ada macam ubat-ubat yang boleh menyebabkan, mungkin kita boleh consider saya akan konteks saya punya colleague in genetic medicine, is there anything yang kita can consider. Kalau ada masalah thyroid, kita rawat dulu yang tu. Okay. Okay, macam mana nak screen? Dia a way of screening lah. So ada a few screening sebenarnya. Dia ada screening ni basically questionnaire, genetic repression skill, ada questionnaire, ada 15 soalan. Ini commonly used. Ini bukannya diagnostic, tapi kita screen. How kita nak screen? Is it ada depression ke tak? Okay. And untuk people yang ada dementia pun kita boleh screen. Dia ada questionnaire dia. Kita tanya pada penjaga simptom-simptom yang mungkin suggest ini ada depression. Or yang paling simple, sebab sometimes masa kalau diorang ada buat healthcare booth kan, sometimes dia akan tanya woolly question untuk just screening whether ada ke tak yang suggestive untuk kata depression. Okay. Bila kita nak screen, so those yang ada risk factor tadilah yang saya mention tu, and those yang ada simptom yang kita cakap earlier. So dia tak adalah kata evidence kita kena screen pada semua elderly. Tak, sebab kadang-kadang tak screen tu mungkin boleh, tapi whether or not kita boleh provide the management. So biasanya screening kita akan buat dekat tempat dibuat oleh orang yang boleh offer the service. For example, macam dekat UMMC, kita boleh lah offer benda ni sebab ada saya genetic secretary yang can manage, and ada my colleague in genetic medicine also can help. So kita tak buat macam random everywhere just for sake of nak buat screening. No. Okay. Ada service baru kita buat. Okay, sekarang kita go untuk macam mana nak rawat. Dah cakap banyak-banyak tadi kan simptom dia macam mana, risk factor dia macam mana. Macam mana nak rawat? Generally kalau nak cakap pasal rawatan, kita ada these 4 main things lah. Psikoterapi, meaning kita bagi terapi. Pharmacotherapy is basically ubat-ubatan, or ada ACT pun kita ada cara ACT and also exercise. Okay. Ni I just go briefly lah. Kalau psikoterapi ni dia ada banyak jenis lah. Interpersonal therapy maksudnya kita bagi one-to-ones lah. So dia study cakap kan, kalau kita combine interpersonal therapy dengan medication anti-depression, dia memang reduce, is very good lah, reduce untuk penyakit depression ni berulang. Okay. Problem solving terapi also can. Kadang-kadang dia adalah isu-isu yang dekat rumah yang kadang-kadang dia tak tahu how to go about, takut macam buat orang terasa. So kita boleh buat problem solving terapi. Kita bukan bagi penyelesaian pada dia. Maksudnya kita guide dia how to end up with the solutions. Okay, cognitive behavior therapy, another therapy yang we can do. Sebab kadang-kadang bila kita depressed, kita banyak sangat cognitive error, kita fikir benda yang negatif. So cognitive behavior therapy ni basically ajar kita how to think a better way, how to challenge the thought. So how to tackle the error dalam kita punya thinking tu. So this is basically yang ada lah. Okay. Okay, kalau kita cakap pasal ubatan, pharmacological treatment is ubatan. Ubatan ni usually kalau kita kata okay, this is depressed and need medication. So medication elderly ni can be selamat sebenarnya. Kita banyak ubat yang selamat untuk elderly, tapi still kita kena consider setiap orang berbeza reaction kepada ubat. So kita kena pilih ubat yang the most safe dengan ada medical problem dia dan keadaan dia sekarang. Sebab kita tahu kadang-kadang elderly patient kita ni banyak medical problem lain. So kita pilih ubat yang sesuai, dos yang bersesuaian. Biasanya kita akan start ubat yang memang selamat untuk mereka. Dos yang kecil dulu sebab kita tahu bila kita dah berumur kadang-kadang fungsi organ kita tak sebagus bila kita muda. Jadi kita akan start ubat yang macam dos yang rendah dulu, bila boleh tak ada side effect kita akan naikkan perlahan-lahan. So itu biasanya cara yang kita buat untuk merawat penyakit dia kemurungan. Dan biasanya untuk options tu banyak. So tak semestinya patient A dengan patient B ubat yang sama. Tak. Sebab kadang-kadang ada juga pesakit saya datang compare masa nak tunggu nak jumpa doktor kan. Dia kat luar, dia macam sembang. Then they say, oh doktor, ada patient before dia yang I talk to, dia on this medication. Why I'm on this medication? So I usually akan explain why I choose this for you, why the other patient is like that. Because different patients, sometimes the response different. Okay. Okay. So how kalau kita nak want to say that the optimal medication kan? So in general, bila kita say that in elderly when we start the antidepressant, we say that if they respond to medication, at least after some time, there are evidence that say that 50% reduction of depressive symptoms, and then after sometimes they can achieve recovery. Okay, and then sometimes they need at least suggest the antidepressant to maybe kadang-kadang kena lama sikit, 10 to 12 weeks in the elderly people. So this is also recommendation by all the study lah. Some may need longer. So it really depends. I tak boleh kata macam, oh everyone have to kena macam ni. This is really individualized. Depend to people to people. Okay, so kalau nak tanya, what is the best anti-depression elderly? Ini pun soalan common juga saya ditanya kan. Yang mana yang paling best, doktor? So actually no ideal anti-depressions for elderly. So dia really individualized, depend to situations and what situation masa tu. Kadang-kadang dia depressed tapi tak ada isu dengan tidur, kita bagi ubat yang anti-depression yang tak berapa mengantuk. Kalau dia depression dia susah nak tidur, kita bagi anti-depression yang mengantuk sikit. So dia tak ada yang kata one medication suit for everyone. This is really individualized. Okay, so, kalau cakap pasal ubat, all ada side effects basically. Tapi usually kita akan choose yang the most safest and the least side effect for elderly. Okay. Also ada ACT, kalau orang dengar, oh bagi current kan, current. So actually current, ACT ni is involved with the, we give the current untuk balance chemical in the brain. Tapi current bukanlah current yang kita as strong as kita boleh switch on, switch off light tu. It's very small punya current yang to induce the chemical balance dalam brain. So there are option of this. Also safe in the elderly. Memanglah dia ada some side effect which is temporary. Tapi it's basically is safe kalau kita kata nak bagi pada elderly. Kita kena careful juga lah lepas bagi tu, kita observe, tengok. Sebab kadang-kadang post ECT tu dia ada confusion sikit. Tapi usually my experience all this while is safe for them. Okay, exercise. Exercise ni pun menarik juga sebab every time that bila saya suggest exercise tu, my elderly patient kata, doktor saya dah tua, doktor macam mana nak exercise kan? Nanti tak larat sakit sini. Tapi exercise ni banyak juga options dia, tak semestinya kena berlari kan. Tapi memanglah study kata kalau kita buat exercise sekali dengan anti-depression is a good macam combination good effect kan. Memang ada two type of exercise yang melibatkan aerobic exercise yang boleh improve kita punya cardiovascular kan. So contohnya walking, running pun boleh, tapi sebab kita tahu elderly kan susah nak running, so they can have walking, swimming kalau pandai yang ni. So this is another exercise I always suggest to my patient. Kalau boleh walk lah, brisk walk jalan sikit kan. Ataupun resistance training, non aerobic also involve kalau nak angkat berat. So sebenarnya kena angkat berat yang macam kita tengok dekat gym tu, mungkinlah angkat botol air kan, yang kita boleh modify yang safe for them lah. Okay. And then study said both exercise ni can help to reduce depressive symptom. Tapi lebih baik kalau kita buat yang aerobic exercise. Tapi it's good ada anti-depression and also exercise. Okay, I think this is my last slide untuk today. So the conclusions today, depression elderly sometimes can be difficult. Memang challenges. Saya pun yang walaupun dah selalu tengok pun kadang-kadang kena treat juga dengan patients kan. Tapi it's come with experience and we know what is the red flag to suggest depression elderly. Usually we able to detect. Okay, and depression elderly has a major impact of quality of life and health. Especially in elderly. And depression is not normal consequences of aging. Sometimes dia kata, biasalah kan orang tua rasa macam sedih sikit, tak happy sikit, letih sikit. No, depression is an illness. So, and it can be treated. So, it's not part of normal aging. And the highest suicide rate is among elderly. Because sometimes they feel that, okay, I have nothing to look forward. I've done everything. So, sometimes bila dia depressed tu tak well treated. They just macam, okay, may just end my life. So, this is another thing why we need to treat them. Okay, and depression elderly very good response with the available medication that we have. Okay, I think that's all for today and thank you for your attentions.
Assalamualaikum and hi, my name is Muhammad Syarul Nazmi bin Roslan as a temporary MC for today. So without wasting time, up next, I would like to introduce Siti Amira binti Muhammad Saad as a speech therapy from the Department of Rehabilitation Medicine, University Malaya Medical Center UMMC. She has been serving at a UMMC for 12 years with extensive experience in focus of swallowing and feeding management in adult and pediatric population. Voice therapy, speech and language problem in adults with aphasia, apraxia, and dysarthria issue. She also actively involved in various professional volunteer, including the International Day of Older People, Mercy Malaysia, Train for Acquired Brain Injury Rehabilitation, Workforce Training, a National Trauma Center, Kathmandu, Nepal. She also has been appointed as a trainer for alternative augmentative workshop with Ikatan Terapis Wicara Indonesia. Also as a senior trainer for the story of Kamandi for our children with autism. She has been an invited speaker for nursing and medical student lecture on speech, language and solving issue in geriatric and dementia care. Without further ado, let's welcome Ms. Siti Amira with the talk about trouble talking or finding word, how speech can help.
Thank you, Shahrul, for the kind intervention. So, hi everyone, I'm Siti Amira binti Masad, speech therapy from Rehab Department UMMC. So, my topic today is trouble talking or finding word, how speech can help. Okay, this is my outline for today. So I will talk introduction about the dementia and also MCI, and it's a brief introduction. Now and then the how MCI and dementia affect on language, role of speech language therapy, how speech therapy can help, how family members can help the patient with dementia, and also the conclusion for our topic today. Okay, so we go to the introduction. So I think previous speakers already talked about what is MCI, what is dementia. So I just give a brief fact about dementia, which is dementia is the umbrella term to describe a group of symptoms, and this symptom may progressively impair usually the memory of a person, a thinking ability of a person, sensory skill, language and also language skill. So the decline in one or more cognitive domain that affect a person independence in daily life. So patient with memory issue, with thinking issue, with language skill issue will affect on their daily life. So this is how and the idea why the dementia is the umbrella term, because under the dementia there is also other type of dementia, which is the Alzheimer disease, which is the highest prevalent of dementia cases. The symptom usually patient will have impairment in memory, got language issue, and also visual spatial skill. And we also have 10 to 20% prevalence of dementia cases, which is the vascular dementia, where patient will have impaired motor skill and also judgment. And other type of dementia such as frontotemporal dementia, Lewy body dementia, and also other dementia such as Parkinson disease, Huntington disease, and also Korsakoff syndrome. Then we go to the fact about the mild cognitive impairment or MCI. So this MCI is a condition that involves the subtle changes in thinking, memory, judgment, and also the language skill. So usually patient with this problem, memory and thinking, that go beyond what is expected with normal aging, but do not interfere with their daily independence. They have the problem, they have the symptom, but it will not interfere with their daily independence. And for the progression, usually patient with MCI, not all will develop dementia, but some are at a higher risk. Okay, now we'd like to talk about how the MCI and dementia affect the language. Usually, both MCI and dementia can cause a language disorder known as aphasia, which can impair a person's ability to speak, to understand what other people told them, or to understand simple and complex instruction. They have problem in identification of written word and also unable to read. They also have problem to write. Okay, the words. Like for example, if you want to say apple, they cannot write the word properly, or they might just write it out with some other incorrect word. So besides of that, there is also specific language problem that include first that most common is the word finding difficulty, or we call it anomia. This is where people struggle to recall the name of family object or using generic term like things. Okay, so usually they have in mind on what they want to talk, what word that they want to say, but it just cannot get out. And sometimes they just say like that thing, I want that thing, just that. Okay, that is word finding difficulty. And we also have the vocabulary changes. So usually an individual may replace a word with a related word or a simpler description. For example, if they want to say chair, but they will say table instead, because usually chair and table is a pair semantically. Okay, you have a table, you usually you will have a chair. So that's why when they want to say chair, they will say table. Or sometimes they just say in a simple description like the thing you sit on, without saying the word chair, but just the thing you sit on. They can also say the words that have same size or same color. Like for example, if they want to say hammer, in their mind they want to say hammer, but they will say like flashlight. And they will also have disrupted conversation. So usually individual may lose their train of thought, have a shorter attention span for listening or repeat themselves. So when people talking to them, at first they will listen, but suddenly it's just like a blank stare. And when you ask again, they will like, I'm sorry, what do you say just now? Okay, or they will repeat themselves. They keep on asking. So like for example, my experience last time, I have one patient. What happened is he keep on repeating and asking the communication partner, how many A's that you got in your SPM. Okay, so we chit-chat, and then suddenly he will ask again, how many A's that you got for your SPM. And then chit-chat again, another topic, and then they will ask again, how many A's that you got for SPM. So something like that. And they will have also jumble or incorrect word. Sentence can contain incorrect word, order or entirely made up. Okay, especially in the later stage of problem. So for example, they want to say horse, but they will say feeble. That is the made up word for the horse. Okay, so or sometimes they just incorrectly word order. They just say, I want to go there. There is horse parking there, things like that. But they just want to say the word horse, but they come out with incorrect word, incorrect sentences. They also have difficulty in understanding, so they might be struggle to follow conversation or understand complex sentences. Okay, as easy as usually with patient, I will ask them, okay, auntie, can you take this paper, fold it into half, and then give it to me? So that instruction is something that difficult for them to do. Okay. How the role of speech therapist in this problem? So usually a speech language pathologist or speech therapist will assess a person's specific cognitive and communication strength and weakness to create a personalized treatment plan. So not all people with MCI or dementia will have same symptom and problem. Okay. And SLP also use a variety of evidence-based technique to help maintain the communication skill. So therapy might not benefit to the patient, to the individual, but also the family members and the caregivers on how they can communicate with the patient. And usually the therapy approach for dementia is more to habilitative maintenance of the skill rather than rehabilitative, meaning that to get the skill back to the normal function. Okay, so this is the evidence-based practice for the word retrieval therapy. Usually patient with because as I said before, the word finding difficulties or anomia is usually the main problem that happen to most of the dementia and MCI patient. So that's why I introduced this word retrieval therapy, so that everyone can try and do with the patient at home. So this exercise focus on reinforcing connection between the words by categorizing them or finding association. This technique calls semantic features analysis to help a person break down a word by its characteristic and function to retrieve it more easily. So this is the example of the semantic features analysis for the object. So what happened is we will put the picture of the target word, like for this slide is the apple, and we will ask the patient to tell us, okay, like for example, what is the superordinate of this picture? Okay, can the patient tell it's a fruit, things like that? Or we can tell how you gonna make action for this, usually how the action that you can do with this. And then we ask also about the physical property. What is the shape? What is the color? So is the patient can tell you either the shape is the shape is round and the red is the color. And we also will ask patient to associate this picture, this targeted picture, with another things like is this sweet? Is this something that you can get easily, where you can get this easily? And we also ask them what is the use of the targeted picture. So we let the patient to mingle around all the question about the targeted picture before the patient can eventually spontaneously get what is the name of the targeted picture, which is the apple. Okay. And this semantic features analysis also not only for object, it can goes with the verbs and other nouns. Okay. Okay. Besides of that, we also giving the prompting or the cueing for the patient. This is very important because sometimes when the patient have a word finding difficulty, they will feel very frustrated. They will like, that word. I want to say that word, but I cannot get it. Sometimes I just show the picture of bottle, like for example, this bottle. I ask them, Uncle, what is this? Do you know what is this? And then they will like, I know this, but I don't know what is this. Okay, so another way that we can help the patient to get the word, the correct word is, we can say the first letter or sound. So like for example, this thing start with W, like for water. So start for W. And see whether the patient can recall or not. Or if not, we just tell them, okay, this start with war, and then let the patient continue with the water. Okay. And then beside of that, we can ask also the category, like for example, is it an animal? Is it a furniture? Is it something you can drink? Things like that. And we use gesture also. We prompt the patient to act out the word with their hands or body. Like for example, this one, the gesture is to drink, like this. Okay. Sometimes we can also write the word. We ask a person to try to write the word out or draw a picture of it. So some patient usually the speaking part, the talking part might not be good, but they are good in writing. Like for example, if they want to say the word water, they might find it difficult, but when you ask them to write it down, they can write it down as water. Okay, so after you write it down, then you can ask the patient to repeat the word. a few times. And then sometimes we describe the word. We ask the person to talk around the word by describing its qualities, function, and location. Like for example, patient difficult to get the word, the targeted word. So we'll ask them, Uncle, can you describe about the word? Like for example, the water. So he can describe something like something to drink, can buy from market, I saw it just now, things like that. Okay, and then to get the patient, and we prompt them until they get the correct word. And then we also have a sentence completion. So we start the sentence and read the word and leave the blank for them to finish. Like for example, when you are thirsty, you drink a water. Things like that. Let the patient finish the sentence completion. Okay. And we also visualize the word. We encourage the person to picture the word in their mind and visualize the first letter and say it out aloud. So sometimes because the patient they say that they know what is it inside their mind, just they cannot get it out. So we'll ask them to visualize how to spell the things inside your mind. So they will close their eyes and imagining how to spell the things and what the first letter, how many letters there is for the word and things. Okay, this is the prompting that we can help for the patient. Okay, some also we can use a memory aids to create something like to create a memory book, which are personalized collection of photos and stories to facilitate conversation about familiar topics. Or we can use visual calendars, written checklists, and communication board can also be effective. Okay, this is the example. So for example, we can have a memory book where we put all the pictures of the patient, the family members, maybe the country that they travel, what is the hobbies and everything, so that we can use this memory book to recall back the patient word finding difficulties and everything that related to the patient that might be easier for them. Okay, and usually the dementia patient also is good that if we have this ID card. Like I have one patient last time, he loves to go jogging and everything, but when he go back home, he just get into the wrong house, and all the neighbors are complaining about it lah, because he just like pecah masuk to the house, something like that. So it's good that we have this ID card, so that we can have the name of the patient, the address, the phone number, and the emergency contact. We tell a little bit about what is wrong with the patient, because the worst scenario can happen is they cannot talk at all. Okay, they just understand you, but they cannot talk at all, they cannot write at all. So this ID card can help them to talk on behalf of them of what happened to their function, to their language function. Okay, and some more, there are also the telephone list that we can do. So instead of the patient need to remember the phone numbers and everything, that might be very difficult for them. So we can just put the picture of familiar people, so that the patient, if they want to call the patient, the person, they just press the button or press the picture, then easier for them. Okay, and this is also the communication book. So some patient, when they cannot talk at all, they cannot write, so the communication book can help. So you can see here the communication book, we can go as simple as like, I want something, I want to go somewhere, something is wrong, TV, food and drink, and this is drink. So all type of the maybe the patient favorite drinks there, so that the patient can, instead of frustrating to tell people what they want, they can just point that I would like coffee with milk. Okay, and easier for them, and not frustrating for the family members also, because they cannot understand what the patient wants to talk. And sometimes without that augmentation of communication, patient first, the family members first, then there's no communication happen at home. So they just like, I do my word, you do your word, things like that. So this is and we don't want that to happen. Okay, so that's why the communication book is something that we can look into, okay, for the patient. And the earlier we use the the earlier stage that we use the communication book, it will be more beneficial for the patient in the later stage. Okay, and there's also a script training, like for people struggling with everyday social interaction, and SRP may help practice specific phrase for routine situation, such as how to order a food. So this can build confidence and reduce cognitive load. So some patient, because they know that they cannot talk, they know that they have problem to recall the word, they not confident to talk with other people, especially when they want to do some routine things like ordering food or buying something. So with the teaching script can improve the topic content, and we can help the patient to speaking rate and increase communication across the variety of situation and listener. And the script can be taught verbally or using a communication book lah. So the script, you can use the communication book, like for example in the communication book you can put a title like how to order a food. So you put there greetings, is it hello, good morning and everything. Then you can put another part of it, I want to buy, things like that. That's the communication book. Or you can have the script like this example. So you can have all the word that how can I help you, we are open, please hold while I get mine, all the things. So whenever patient wants to communicate with the person in the shop, so they can just like look at this and try to recall back the word and try to say it out. Okay, so they be more confident because there's something that they can look into without just being forgetting the word. Okay, then beside of the speech therapy role for the patient with dementia and MCI, we in our session also we really help. We will train the parents, we will train the caregivers on how they can help the patient. Okay, so like for example, when talking with the patient, we need to simplify the communication. Use short, simple sentences and speak calmly and clearly. Avoid complex sentences or ambiguous question. So if you want to say like, Mak, you need to makan. Mak, nak makan makanan atas meja. So you use simple. You don't use like, Mak, ni ada nasi ni, nanti mak makan atas meja ke, kita letak atas meja, that very long. So they will lose attention about it. So just say, Mak, sekarang time makan, mak duduk atas kerusi makan nasi. Okay, and sometimes we have to provide time to respond also. We have to allow plenty of time for the person to process information and formulate a response without interrupting them. Like for example, if you like, okay, what do you want to eat today? If you ask your mom, so give them time to respond. Don't just they might, because they have that word finding difficulties and everything, so they need time for them to think and respond. So then don't like macam simply, what do you want to eat? Tell me, what do you want to eat? You have something you want to eat? You want to eat now? You want to eat later? So when you keep on asking them like that, they are very frustrating because it's very difficult for them to think, to focus, and to tell them the answer, to tell us the answer. And we need to minimize the distraction also. We need to hold the conversation in a calm, quiet environment with minimal background noise, because they have short attention span. They might not able to understand complex complex instruction. So distraction, if we minimize the distraction, this will help them more. Okay, and we should ask simple question, and instead of open-ended question like what do you want for dinner, we will ask them like, do you want fish or chicken for dinner? Okay, more specific question. Okay, so we go to the end of the topic. So I think the speech therapy benefit individual with early dementia by helping to maintain the communication skill, improve social engagement, and adapt the environment for better quality of life. So early intervention with the SLP can provide strategies to manage the symptom, such as using a compensatory aid like calendars or alarm or communication book, and can reduce frustration for both the individual and their families. The therapy also to help the individual express their needs and emotion. And we can advise on making environmental changes like reorganizing a living space for clarity or minimizing background noise to better support communication. So we can suggest for the family members on how to make the environmental changes at home, and how to tackle the patient at home. And also the therapy also include providing an advice and support to the family on how to best communicate with the individual, because sometimes the family members also, they don't know whether the parents got this issue because of dementia or just mengada-ngada, things like that. Because there is a patient that when they have dementia, the personality also change. Maybe before this they talk softly, they are soft spoken person, but when they have dementia, the personality change, they become more violent and everything. So we need to tell the family members that this is something related to dementia. It's not like something that it just happened, so that they understand that my mom happened this and they know what to do with it. So that is the end of my talk today. Thank you so much for listening, and I hope that this will give some insight for all people to help our family members in dementia and MCI problem. Thank you.
Okay, thank you Ms. Siti Amira for the insightful knowledge on aphasia in dementia and strategies to maintain the patient language ability. Okay, that's all from me.
Thank you, Shahrul, for being the temporary MC. Okay, now I'm your MC again for today. So up next, let's have Miss Nur Faizah binti Norizan, our physiotherapist, sharing some easy home tip to keep the body and mind active. Okay, over to you, Kak Fazia, Kak Faizah.
Okay, thank you. Alright. Okay. So the slide. Okay. So, Assalamualaikum and good morning. Okay, I'm Nur Faizah. Okay, physiotherapist from Rehab UMMC. Okay. And then I would like to give talk on topic keeping the body and mind active, easy home tips from the physiotherapist perspective. Okay. Okay. The content is, first I will talk on introduction, exercise a key to healthy living, why should older adults exercise, easy home exercise, how can falls be prevented, and advice to carer or caregiver. Okay, for the introduction, okay, physical activity versus exercise in older adults. Okay, what is physical activity? Is any bodily movement produced by skeletal muscles that requires energy expenditure, includes daily tasks, walking or gardening. But for the exercise, is a planned, structured, repetitive physical activity with the goal of improving or maintaining fitness components like strength, balance, or endurance. Okay, example for the older adults, okay, for the physical activity is taking the stairs, doing house chores, or walking to the shop. Okay, but for the exercise it's different. Okay, doing chair exercises, balance training, or tai chi a few times a week. Okay, for the key message, all exercise is physical activity, but not all physical activity is exercise. Okay, meaning, okay, such as doing the chair exercise, meaning sit to stand, balance training, it's an exercise, but it's not a physical activity. But taking the stairs, doing house chores, or walking to the shop is a physical activity. Okay, both are important. For the physical activity keeps you moving daily, and exercise helps you stay strong, flexible, and independent. Sekali lah. Oh, sini. Tekan balik, lepas tu tekan. Jadi lah. Tak boleh. Tak bagi dia sana tu. Depan pula. Okay. Okay. For the exercise, a key to healthy living, okay, it's a boost to the immune system. Why? When you do exercise, your body become healthy and also can immune the system. Okay, boost the immune system. And also it helps prevent disease of affluence such as cardiovascular, diabetic, and obesity. Okay, it's also help promote and maintain positive self-esteem. When you do exercise, of course, you feel better, okay, and your mind also will become positive. Alright, to improve mental health, okay, dementia decline, and also improve and maintain steady digestion. Alright. Okay, why should older adults exercise? Okay, why? To improve mobility and independence. When you do your exercise every day, okay, will strengthen your hand and legs all, so that your activity, daily living, what you do every day will be independent. Okay, alright. For prevention, okay, as I said just now, when your leg and hand strong enough, okay, will prevent the fall. How? Because if your hand strong, okay, your hand can grip stronger to your chair or table when want to fall. Okay, for pain management, meaning if you got any arthritis, we do exercise, then can reduce the pain. Okay, for chronic disease management, okay, this one, if you feel any problem, okay, so if you do your exercise, the disease, the problem will become lesser. Okay, so for enhanced mental and cognitive health, this one, okay, when you have your problems all, okay, if you do your exercise regularly, it will become lesser. Okay, the mental health will become better also. Okay, recovery from injury or surgery. If you do surgery or injury, as example at the knee, okay, knee surgery, when you do your exercise, then your pain become reduced and your movement become better. Alright, to increase quality of life, if you maintain doing exercise every day, okay, will increase your quality of life. Okay, easy home exercises. What is the exercises? Okay, okay, general exercise prescription. Okay, first, moderate aerobic activities, okay, for brisk walking, cycling, swimming. Okay, normally older adults will do the brisk walking. Okay, so you can do for 150 minutes a week. Okay, meaning 30 minutes in 5 days. Okay, for strengthening exercise, at least 2 days a week. Okay, 8 to 12 repetitions each exercise. Okay, for the balance exercise, at least 3 days a week, 30 minutes each session. For stretching exercise, at least 2 days a week, 10 minutes each session. Alright, so what is the exercise? Okay, for sit to stand activities, okay, consist of sit to stand exercise, but for the progression, for the improvement, okay, we will do with the cone and rings. Okay, the patient need to stand and get the rings and then put and sit again and then stand again. Okay, so for sitting and standing balance and also repetition movement. Ada video. Okay. Video. Okay, farmer walking exercise, okay, consists of walking with weights using the dumbbell or water bottle. You just use whatever you have at home. If you have the water bottle, then you use. If you don't have the water bottle, if you have the dumbbell at home, better you just use the dumbbell, but according to your older adults, what can they can lah, okay, the weights. Okay, but for the water bottle, you can put either water or any rock or anything to make it heavier. Okay, for variation, you can do either zigzag or obstacle. Video. Okay, so this patient, the older adult, in the video just walk straight line. Okay, alright. Okay, so catch and throw ball. Okay, objective for standing balance. Okay, training reaction time and eye hand coordination. Okay. Okay, alright. So the physio or carer can hold the patient at the back. Okay, just throw from the other way also. Okay. Okay, multifunctional activities consist of walking figure of 8, obstacle exercise, and also cone and rings. Okay, you can do this at home. Okay, can find it at the toys shop for the ring and cones, and for the obstacle you can use anything at home. Okay, just walk figure of 8. Okay, for the balance and coordination also. Okay, alright. Okay, climb up and down stairs consists of dynamic standing balance, turning to right or left, and pick object. If patient can walk by themselves, then let it be. But if cannot, we just hold the older adults. Alright, good. Okay. And then do the turning. And then climb up and downstairs again. Okay. Okay. How can falls be prevented? Okay. Orientate older adults to the surrounding environment daily or more if the patient is confused or disoriented. Ensure older adults uses their glasses and or hearing aids and walking aids if required, and keep the older adults' possession within safe reach. Okay, put the glasses or hearing aid beside the bed. Okay, beside the chair. Okay, advise on the use of covered shoes or non-slip footwear to prevent slipping and prevent fall. Okay, ensure that clothing is not interfering with the older adults' mobility, and also secure a call bell at the bed table or bed head if possible. Instruct older adults to call for assistance. Okay. Alright. For the advice to carer or caregiver, okay, supervise and assist ambulation and activities of daily living when necessary. Okay. Increase frequency of observation if older adults are unable to call. Okay. If older adults are confused and mobile, place a padded area beside the bed. Okay. This one you can do. Okay. At home. Okay. Family involvement and caregiver training for ongoing support and safety during episodes. Okay. This is the reference. Okay. Ada satu. Ada. Okay, this is our team for geriatric outpatient physiotherapist 2025. And thank you for your attention. Thank you very much.
Thank you, Miss Nur Faizah, for those simple yet effective exercise. Definitely something we can all try at home. Boleh beli barang kat Shopee also kan. Okay. Without further ado, now let's hear from Mr. Muhammad Sharul Nazmi bin Roslan, a staff nurse who will speak on how nurses support you through memory changes. Before that, let me introduce Mr. Muhammad Sharul Nazmi, who has been dedicated staff nurse at geriatric ward since 2018 with 3 years experience as enterostoma nurse at geriatric ward. He also actively participated as volunteer for Alzheimer Day in year 2002 and 2023. Without further ado, let's welcome Mr. Muhammad Sharul Nazmi bin Roslan on his topic, how nurses support you through memory changes.
Hi, Assalamualaikum and very good morning. So my name is Muhammad Sharul Nazmi bin Roslan, and for today I will give a talk regarding on how nurse support you through the memory changes lah. So for your information, I already work for geriatric ward for 7 years, and a lot of experience that I have been and I also approach many patients with the patient that have a memory changes lah. Okay. Okay. So this is my introduction regarding on memory changes, and dementia is usually a common cognitive disorder that usually that affect thinking, especially in elderly. Seperti yang kita tahu, bila kita bercakap tentang perubahan daripada segi memori pesakit, orang tua memang kerap sangat kita kaitkan dengan masalah daripada segi memori. Tapi untuk pengetahuan semua, masalah memori ataupun demensia itu bukanlah satu yang normal kepada pesakit yang mempunyai masalah yang daripada segi memori lah. Okay, selain daripada itu, masalah ini ataupun this cognitive disorder bukan saja it will also impact memory. Dia akan impact kepada bahasa, language, judgement, cara dia buat keputusan, perception and also behaviour. Dia bukan saja merubah, maksudnya daripada segi orang kata pesakit, daripada segi dia punya behaviour pun boleh berubah. Selain daripada itu, untuk pengetahuan semua, it is a progressive ranging from mild impairment to severe dependency in daily activity. Jadi ianya boleh menjadi semakin teruk daripada mula-mula dia tak berapa ingat sampai dia akhirnya dia tak boleh untuk melakukan sesuatu aktiviti itu sendiri, akibat dia mempunyai masalah daripada segi ingatan. Okey. Seterusnya, apakah itu bila kita cakap pasal dementia? Dementia is a syndrome characterized by a group of symptoms that affect memory, thinking, social ability and daily function to the extent that they interfere with a person everyday life. Maksudnya dementia ni adalah sindrom yang orang kata group of symptom yang menyebabkan gangguan kepada memori daripada segi cara dia berfikir, cara dia bersosial dengan orang ramai, keluarga, dan juga akan akhirnya akan efek kepada dia punya activity daily of living. Jadi dia akan susah untuk buat macam contoh macam makan, dia akan lupa makan, dia akan lupa cara untuk buat sesuatu aktiviti dalam dia punya kehidupan harian dia. Okey, ini adalah 10 warning sign of dementia. Yang pertama sekali adalah memory loss. Usually orang tua ataupun older people that have dementia problem will have a memory loss. Dia akan lupa siapa anak dia. Kadang-kadang dengar ni skandal mana ni, dia kata yang ada dengan suami dia, padahal tu anak dia. Kadang-kadang memang dia akan susah untuk ingat lah sesuatu tu, especially memori-memori yang lama. So yang kedua adalah difficulty performing familiar task. So kalau sebelum ni, sebagai contoh, kalau sebelum ni dia boleh memasak, ada kemungkinan untuk dia lupa cara untuk memasak tu sendiri. Kadang-kadang ada kes sampai dia lupa nak tutup api lepas dia memasak. So benda-benda macam tu akan menyusahkan dia lah. Yang ketiga adalah dia akan ada masalah daripada segi bahasa. Kadang-kadang kita bercakap dengan dia, tiba-tiba dia senyap sebab dia lupa perkataan yang dia nak sebut tu sendiri. Seperti yang diberitahu oleh speech therapy kita yang sebelum ni lah, Puan Amira. Yang keempat adalah berkenaan dia akan lupa, maksudnya disorientated to time and place. Maksudnya dia akan lupa dia ada kat mana, sekarang dah pukul berapa. Kadang-kadang bila pesakit sendiri yang datang ke ward, kadang-kadang bila dia masuk time malam, dia ingat dah pagi. So tu yang dia kadang-kadang ada pesakit yang tiba-tiba cakap kat kita, pakcik nak kena pergi pagi ni pakcik ada appointment ni, padahal dah malam. Yang kelima adalah poor or decreased judgment. Maksudnya dia sukar untuk membuat keputusan disebabkan dia ada masalah daripada segi kebolehan dia untuk berfikir. Yang keenam adalah dia problem untuk keeping track of things. Kadang-kadang dia akan lupa lah, maksudnya daripada segi apa benda yang disimpan. Kadang-kadang so dia akan berlaku masalah yang ketujuh, iaitu misplacing thing lah. Dia akan kerap letak benda, contoh macam kunci ke, sepatutnya ada dekat tempat kunci, dia letak kat tempat lain, tiba-tiba dekat dapur pula. Itu antara contohnya. Yang ke-8 adalah change in mood and behaviour. So bila orang yang mempunyai masalah ingatan ataupun demensia ni, dia akan ada susah masalah daripada untuk maintainkan dia punya behaviour, dan behaviour dia juga mungkin boleh berubah-ubah. Kalau kita kenal dia dulu sebelum ni, dia seorang yang baik, apa tu semua, bila dia ada masalah tu boleh menjadi seorang yang agak agresif. Tu antaranya lah. So yang ke-9 adalah challenges understanding virtual and spatial information. So untuk orang yang mempunyai masalah demensia ni, dia mungkin ada masalah untuk memahami informasi yang dia lihat ataupun ni, sebabnya mungkin informasi tersebut maksudnya tiada dalam otak dia. Itu yang menyebabkan dia mempunyai masalah lah untuk memahami apa yang dia tengok. Yang ke-10, dia mungkin akan withdrawal from work ataupun social activity. Sebab sebelum ni mungkin pesakit boleh buat maksudnya kerja macam biasa, tapi bila dia mempunyai masalah ingatan, dia terlupa cara untuk dia melakukan kerja tersebut, dan sedikit sebanyak benda tersebut mengganggu dia punya kehidupan dia ataupun dia punya aktiviti sosial. Okey. Okey. So, apakah kesan orang kata demensia ni kepada pesakit? Yang pertama, pesakit tersebut akan mempunyai kesukaran dalam berkomunikasi, ataupun dalam bahasa Inggeris difficulty in communication. Dia akan ada masalah afasia, dysarthria, maksudnya susah untuk menyebut perkataan tersebut atau dia lupa perkataan tersebut. Yang kedua, dia mungkin akan impact cognitive function lah, macam saya cakap. Dia akan menyebabkan dia lupa di mana dia, siapa dia, dia akan lupa anak-anak dia, dia akan lupa tentang masa. Itu antaranya lah. Yang seterusnya adalah loss of independence. So bila pesakit yang ada masalah demensia ni lupa untuk orang kata untuk makan, untuk minum semua, dia hilang kebolehan untuk dia berdikari. Dan menyebabkan perlunya seseorang ataupun someone untuk take care of the patient itself lah. Selain daripada itu, akan ada masalah poor nutrition. So mungkin saya rasa ramai yang selalu orang kata menghadapi situasi ni, yang mana pesakit selalu cakap, makcik makanlah. Oh, makcik dah makan dah tadi makcik makan banyak. Ni makanan ada kat sini lagi makcik belum makan lagi. Kadang-kadang dia lupa bahawa dia belum makan lagi, ataupun dia ada masalah daripada segi untuk menelan. Dia lupa cara untuk menelan makanan itu sendiri, dan menyebabkan pesakit itu menghadapi masalah daripada segi nutrisi. Yang seterusnya adalah impact ADL, activity daily of living, dengan and patient safety. Bila pesakit tersebut mempunyai masalah daripada segi orang kata ingatan, dan menyebabkan dia susah untuk membuatkan activity daily of living, keselamatan pesakit mungkin akan menjadi orang kata akan membahayakan pesakit lah. Bila pesakit lupa cara untuk berjalan dengan betul, so akan menyebabkan dia ada kemungkinan ada risiko yang agak tinggi untuk jatuh. Selain daripada itu, penyakit demensia ni juga memberikan orang kata emotional impact. Jadi pesakit tersebut akan lebih kurang keyakinan diri, anxiety, dia akan maksudnya akan social withdrawal, maksudnya dia akan elak daripada berjumpa dengan orang-orang yang dia kenal, dengan kawan-kawan dia, disebabkan oleh dia mempunyai masalah daripada segi ingatan dan juga dan benda tu mengganggu dia daripada segi emosi lah. Okey, seterusnya. Okey, so apa kesan orang kata demensia ataupun masalah cognitive function ni lah kepada keluarga dan juga kepada penjaga? Yang pertama sekali, tentulah emotional and physical stress lah. Cuba anda bayangkan, bila seseorang yang mempunyai masalah ingatan dan selalu bertanya soalan yang sama kepada anda, dan benda tu menyebabkan bukan saja, saya rasa sesiapa saja akan berasa stres lah bila ditanya soalan yang sama. Lepas tu anda kena bila dituduh kan, cakap anda mencuri lah dia punya barang apa tu semua, padahal rupa-rupanya barang yang dia ni ataupun dompet tersebut rupa-rupanya dia salah letak, dan dia tuduh anda, mengatakan anda yang mencuri. Selain daripada itu adalah social isolation dengan relationship strain. So bila pesakit tersebut mempunyai masalah daripada segi demensia, hubungan anda dan juga maksudnya hubungan keluarga dan juga pesakit mungkin akan jadi semakin renggang, disebabkan ada masalah daripada segi komunikasi. Anda pun stres dengan pesakit, dan benda tu akan menyebabkan orang kata keluarga tu menjarakkan diri daripada pesakit tersebut. Yang last sekali adalah financial strain lah. So macam yang saya cakap tadi, bila pesakit mempunyai masalah demensia, dia akan susah untuk orang kata untuk bergerak, akan ada masalah incontinence. So banyak benda yang mungkin memerlukan duit untuk untuk menjaga pesakit tersebut, dan ada sebahagian orang kata penjaga sampaikan terpaksa berhenti bekerja untuk menjaga pesakit demensia tersebut, disebabkan oleh pesakit demensia ni fully orang kata bergantung kepada penjaga tersebut. Dan hal tu orang kata agak menyusahkan dan akan memberikan financial strain lah kepada keluarga tersebut. Okey. So apakah orang kata tugas jurawat lah, ataupun what is the role of nurse in supporting memory changes? Yang first kali, nurse as a key provider of compassionate care and safety advocate lah. Yang pertama kali kita akan deliver person-centered empathic care and respect the individuality and dignity. So apa-apa keputusan berkaitan dengan penjagaan orang tua, kita kena melibatkan pesakit tu sendiri. Maksudnya bukan daripada keputusan tu bukan daripada kita sendiri. Kita kena ambil orang kata dia punya pandangan juga. Sebabnya kalau kita just buat keputusan berdasarkan daripada kita sendiri, bukan orang kata person-centered empathic care, mungkin cara kita melakukan orang kata penjagaan tu akan menyusahkan pesakit tersebut. Yang kedua adalah promoting quality of life and well-being throughout different stage of dementia. Maksudnya jurawat itu sendiri mempromot atau mempromosikan quality of life kepada pesakit tersebut mengikut stage-stage dementia tersebut. Maksudnya kalau pesakit tu masih lagi boleh buat aktiviti daily of living, just kena tolong, maksudnya dia bantulah daripada segi tersebut. Yang ketiga adalah give support to patient, family and carer, and also advocate for their need. Maksudnya kita bukan saja attend kepada pesakit tersebut, tetapi kepada keluarga dan juga penjaga berkenaan dengan apa yang diorang perlukan. Sekiranya diorang perlukan daripada segi financial ada masalah, mungkin kita akan refer kepada social welfare. Lepas tu kalau daripada ni mungkin ada masalah daripada segi emotional, mungkin kita akan refer kepada doktor ataupun ni untuk counselling. So sedikit sebanyak dapat mengurangkan beban orang kata pesakit dan juga family dan caregiver lah. Okey. Okey, seterusnya adalah yang keempat adalah ensure dementia friendly environment. Bila kita sebut pasal dementia friendly environment, maksudnya kita memprovidekan ataupun menyediakan kondisi ataupun orang kata persekitaran yang mesra dengan pesakit dementia ini. Contohnya, kalau pesakit tersebut ada masalah daripada segi bergerak, mungkin kita providekan barang-barang ataupun equipment untuk membantu dia untuk melakukan orang kata untuk memudahkan dia pergi ke tandas ke, sedikit sebanyak dia boleh membantu pesakit tersebut. Kalau contoh kalau pesakit tinggal di rumah, kalau ada orang kata susunan tu kalau boleh try untuk kita dekatkan bilik dia dengan bilik air, so mudah untuk pesakit pergi ke tandas. Selain daripada tu, orang kata elakkan daripada environment tu terlampau berkecah ataupun terlampau banyak barang yang sehingga menyusahkan pesakit untuk bergerak. Yang kelima adalah coordinating multidisciplinary care to maintain safety and comfort to patient ataupun dalam kurungan holistic care. Maksudnya jurawat orang kata sebagai ni mengarahkan ataupun membantu daripada segi, sebab kita bila menjaga pesakit dementia ni bukannya jurawat seorang je yang menjaga. So akan ada speech therapy, akan ada fisioterapi, akan ada orang kata doktor, akan ada dietitian. So kita bersama-sama dengan ni sebagai satu tim membantu pesakit memberikan penjagaan secara keseluruhan, secara holistik, supaya tiada orang kata keperluan pesakit tu yang terabai. Okay. Okay. Next. Okay. Seterusnya adalah early recognition of memory changes and referral to appropriate service lah. So kita sebagai jurawat perlu orang kata kenal lah tanda-tanda awal berlakunya perubahan daripada segi memori kepada pesakit, dan juga kita refer pesakit tersebut kepada servis yang bersesuaian. So first, noted any changes to patient related to memory such as forget where they are. So kita masukkan orang kata sebarang perubahan berkenaan dengan orang kata memori di dalam kita punya report lah, supaya at least doktor dan juga sesiapa saja orang kata noted yang bahawa pesakit tersebut mempunyai masalah daripada segi kognitif dan juga memori. Yang kedua, mungkin kita akan menggunakan assessment tool. Contohnya seperti Montreal Cognitive Assessment ataupun MOCA ataupun Mini Mental State Examination, MMSE lah, kepada pesakit yang kita rasa pesakit ni ada masalah dengan memori ni. So kita nak assess ataupun kita nak check sama ada berapa teruk pesakit tersebut mempunyai masalah daripada segi kognitif dan juga memori. Yang ketiga adalah refer patient to memory clinic or specialist for further assessment and treatment. So kita refer pesakit tersebut, once kita dah buat assessment, mungkin kita akan refer pesakit tersebut kepada memory clinic ataupun specialist yang lebih pakar berkenaan dengan ni untuk treatment dan assessment yang lebih lanjut. So yang seterusnya adalah jurawat ni bertanggungjawab untuk supporting family and caregiver with education and resource. Yang pertama sekali adalah untuk provide information related to understanding dementia, communication strategy, managing dementia related behavior, legal and financial planning and stage of dementia. Maksudnya dekat sini seorang jurawat tu perlu memberi informasi lah berkenaan dengan macam mana penyakit dementia ni, tahap-tahap dia macam mana. So kita kena tahu juga maksudnya expectation family tu macam mana. Sebab kadang-kadang kebanyakannya selalunya family tak tahu berkenaan bahawa dementia ni merupakan satu penyakit yang progresif dan tiada ubat lah. Maksudnya kita just memperlambatkan lagi dia punya simptom saja. So bila expectation diorang tinggi dan diorang expect bahawa patient boleh kembali seperti asal, benda tu menyebabkan patient, keluarga dan juga caregiver menjadi stres. Sebab dia mengharapkan patient tu menjadi elok semula, tapi rupa-rupanya dia punya simptom tu akan semakin progresif. Yang kedua adalah provide support group for family and caregiver to share experience and advice. Mungkin kita providekan group-group yang berkaitan dengan pesakit dementia ni supaya diorang boleh share experience, macam mana pengalaman diorang. Setiap orang mempunyai experience yang berbeza. So bila diorang share sedikit sebanyak, boleh bagi advice ataupun tips yang sesuai lah untuk pesakit penjaga berkenaan dengan penjagaan pesakit dengan masalah dementia. Yang ketiga adalah helpline and counselling. Contohnya ada NGO macam Alzheimer Disease Foundation Malaysia. So diorang ada providekan daripada segi counselling kepada penjaga dan pesakit. Diorang ada providekan caregiver juga untuk pesakit-pesakit yang mempunyai masalah dementia ni. Lepas tu selain daripada tu, diorang juga ada respite care, ada information juga. Itu antara servis yang diorang provide lah. Itu adalah contoh saja untuk helpline and counselling. Okay. So seterusnya adalah nursing assessment, regular and mental status assessment. So maksudnya nurse bertanggungjawab untuk assess lah. So daripada segi kita interview family, macam mana pesakit ni, so observe macam mana, adakah terdapat perubahan daripada segi behavior. Yang kedua adalah kita assess risk. Kalau pasien tu ada high risk untuk jatuh ke, agitation and medical adherence. Maksudnya kita tanya family dan juga pesakit berkenaan macam adakah pesakit ni ada high risk untuk jatuh, adakah dia makan ubat tu mengikut waktu dan juga ubat tu. Yang selain daripada tu, adakah pesakit ni selalu agitate kalau time dekat rumah macam mana. So kita akan tanya pasal behavior dia time dekat rumah. So yang seterusnya adalah intervention, nursing intervention lah, patient with memory problem. So yang pertama adalah reality orientation and communication. Maksudnya setiap hari kalau boleh kita try untuk bagi orientasi kepada pesakit tersebut lah. Kalau boleh, kalau ada tools lagi bagus, contoh macam kalender, ada jam, so memudahkan kita untuk memberikan orientasi kepada pesakit tersebut. So diorang tahu hari ni berapa hari bulan, jam sekarang pukul berapa. So daripada segi communication, kita menggunakan komunikasi yang bagus lah. Maksudnya menggunakan simple word, bukan ayat-ayat yang terlalu kompleks. Selain daripada tu, menggunakan tidak meninggikan suara. Lepas tu yang kedua adalah frequent orientation to time, place and person using clock, calendar and family object. Ni yang macam saya terangkan tadi lah, berkenaan dengan kalau masa kita buat orientasi, better untuk menggunakan tools lah. Contoh macam jam, kalender dan juga family object. Selain daripada itu, yang ketiga adalah using simple explanation. Kalau boleh, gunakan explanation yang senang untuk difahami, face to face communication dan menggunakan intonasi yang tenang. Kadang-kadang ialah kita nak marah tapi tak boleh. Kita kena faham lah condition dia macam mana kan. Dia ada masalah dengan ingatan, macam tu. Yang keempat adalah provide positive feedback to encourage appropriate behavior. Maksudnya bila pesakit tiba-tiba aggression, jangan kita agresif juga. Jangan kita pukul balik pesakit tu. kalau boleh try tanya dulu kenapa tiba-tiba dia nak agresif, kenapa tiba-tiba dia nak pergi ke tandas. Rupanya dia nak bangun sebab dia nak pergi ke tandas. So kita pula tak bagi. So kita kena explain dengan baik-baik. Kalau boleh explain dengan baik-baik, maksud tenangkan dia dulu. Lepas tu gunakan suara yang tenang untuk bercakap dengan dia. Okay, lepas tu ni safety measure lah. So first kali adalah kita create safe environment by removing hazard and familiarity patient around patient surrounding. Maksudnya kita buang benda-benda ataupun alihkan benda-benda yang boleh menyebabkan atau boleh membahayakan pesakit lah. Dengan selain daripada tu mungkin kita letakkan juga benda-benda yang patient tu familiar, supaya dia kenal lah dengan surrounding dia. Yang kedua, kita apply fall prevention and wandering prevention protocol lah, like dog alarm, supervision, mungkin boleh pasangkan CCTV juga. So kita selain daripada tu, saya pernah jumpa ada keluarga pesakit lah yang siap print lagi nama, alamat tu semua dekat baju, untuk elakkan daripada pesakit tu orang kata hilang. Selain daripada tu, medication management. So kita nak monitor lah daripada adakah pesakit tu makan ubat tu ikut time yang ni ataupun dia makan tak ikut masa ke. So kita kena tengok juga ubat-ubat tu, ada tak ubat-ubat yang boleh men-trigger ataupun memburukkan lagi keadaan dia daripada segi kognitif. Mungkin ubat-ubat tersebut mungkin orang kata perlu di-off-kan. Itulah. Okay. So managing challenging behaviour. So yang pertama sekali, untuk teknik to discourage suspicion and false idea. Maksudnya kita wujudkan orang kata rutin ataupun kita reorientation balik kepada pesakit. So ni siapa supaya diorang boleh elakkan daripada suspicion dan juga false idea. Yang kedua adalah close observation for delusional or violent behaviour. So untuk jurawat, kalau boleh untuk pesakit-pesakit yang ada masalah delusional ataupun violent behaviour, kalau boleh kita try untuk letak ke nearest to the counter of the nurse lah. So senang untuk kita monitor dia. Yang ketiga adalah de-escalation training for nurse to handle agitation and aggressive safely lah. Maksudnya kita train jurawat cara macam mana nak handle agitation, maksudnya menggunakan komunikasi yang berkesan, lepas tu reorientation, lepas tu benda-benda macam tu lah. Okay. So supporting caregiver and family. So first kali kita akan educate tentang cara untuk orientate and cara untuk komunikasi dengan pesakit lah. Maksudnya kalau bercakap tu kena face to face, suara yang tenang, nada yang tak terlalu tinggi. Yang kedua, kita akan teach pasal safety measure and reinforce positive behaviour at home. Maksudnya kita akan beri penerangan sedikit berkenaan dengan apa yang perlu dilakukan lah kalau dia balik nanti. Maksudnya mungkin cakap tadi pasal CCTV tu semua, ataupun grab bar ke untuk membantukan pesakit tu untuk ni. So kita akan access daripada segi equipment dan semua yang diperlukan dekat rumah. Yang ketiga adalah emotional support and resources navigation for caregiver. So kita beri support daripada segi emosi dan juga resource lah. Maksudnya kalau apa-apa ni dia boleh rujuk kepada kita. Itu antaranya lah. Okay. Okay, last kali, ni next adalah documentation and evaluation. So pentingnya kita sebagai jururawat untuk dokumen sebarang behaviour observation and also nursing care plan lah, response to intervention. Maksudnya kita record dalam kita punya nursing care, maksudnya apa yang kita buat, so apa yang berlaku, perangai dia macam mana, so apa yang kita lakukan, macam mana respon terhadap perawatan yang kita telah berikan. Next kita evaluate patient lah. Kalau dia boleh, patient can distinguish reality with caregiver support. Maksudnya pesakit boleh ni lah antara reality dengan memberikan support kepada penjaga. Selain daripada itu adalah adjusting care plan based on ongoing assessment. Maksudnya kita memberikan perawatan berdasarkan pesakit, berdasarkan kepada keadaan pesakit. So kalau dari masalah ni, kita contoh macam masalah daripada segi untuk bergerak ke apa, so kita try untuk bantu dia untuk bergerak, mungkin dengan menggunakan equipment dan semua itulah berdasarkan daripada kondisi pesakit. So conclusionnya, nurse provide compassionate person-centered care for individual with dementia, contribute to early recognition, diagnosis and management. They educate, advocate and also develop individual care plan to promote dignity, respect and quality of the life. Nurse also support caregiver by offering practical advice, emotional support and guidance on managing behavioural symptom. So itu sajalah daripada saya. Sekian, terima kasih.
Thank you, Mr. Shahrul Nazmi, for highlighting the caring and crucial role that nurses play in supporting older adults and their families. Now, I would like to invite Tuan Muhammad Yazil bin Mahmud, our medical social workers, who will speak on where to get help, services and support that matters. Please welcome Tuan Muhammad Yazil bin Mahmud.
Okay, Assalamualaikum dan selamat tengah hari. Terima kasih kepada pengerusi majlis. Saya Muhammad Yazil bin Mahmud. Saya adalah pegawai kerja sosial perubatan di Pusat Perubatan Universiti Malaya. Now in charge of geriatric patient, especially from geriatric ward and from the clinic. I'm in charge this clinical since 2024. So before that, I'm also in charge of patient from the psychiatric, from the ID and everything lah. So, but for since 2024 till now, I'm covering this clinical, iaitu geriatric. My slide in English, but I will talk in Malay so that people lebih mudah memahami apa yang bantuan-bantuan atau servis yang boleh diberikan to patient, especially patient B40. Okay, this is a role of social worker. I don't want to explore more about this. So I think people know about this. What is social worker do in this hospital, especially to make sure patient get the bantuan from social aspect, physical aspect, and also from the socio-economic aspect. So usually we focus on three aspect, iaitu social, physical, dan socio-economy lah. Okay, socio-economy more to the tahap kemampuan kewangan pesakit, dari segi pekerjaan, dari segi pendapatan, dan dari segi what we call dari segi support from EPF, SOCSO, where the patient terima JKM or not. So all the things we do the assessment lah. So that's why kita akan trying to understand what is a social issue, what a physical issue, what is a socio-economic issue before kita try to develop bantuan ataupun care plans untuk pesakit-pesakit, especially for warga emas. So normally dekat PPUM ni, referral for social worker ada 4 aspek ataupun 4 perkara utama yang dirujuk. Yang pertama adalah financial help or financial assistance, bantuan kewangan. Yang kedua adalah berkaitan dengan discharge issue, discharge planning. Dan yang ketiga berkaitan dengan emotional support or counselling. Dan the last one usually refer for practical assistance regarding the guidance and resources for social support, especially for OQ card, bantuan kewangan JKM, or isu-isu berkaitan dengan penderaan, or isu-isu berkaitan dengan pencen ilat, SOCSO dan sebagainya lah. Ini merupakan perkara-perkara utama yang sentiasa dirujuk di clinical geriatric, especially untuk membantu pesakit-pesakit warga emas. Kalau financial assistance tu kita akan lihat kepada more to bantuan-bantuan yang berupa bantuan peralatan, special drugs, dan juga bantuan yang berkaitan dengan lately ni ada test yang dirujuk. So kita cuba lihat sama ada kita boleh membantu ataupun sebaliknya. So kita go one by one, sebab saya nak tunjukkan every aspect ni bagaimana you all boleh dapat this service dan cara untuk memohon lah. Okay. So what we support financially is medication, especially kalau di geriatric more refer for the ubat denosumab lah. So amat jarang sekali untuk ubat-ubat lain. I think ubat-ubat kebanyakannya adalah standard pemiluri except the denosumab. So the second one, bantuan berkaitan dengan equipment, yang ini paling banyak dirujuk lah di PPUM, especially di geriatric ward. Wheelchair, ripple mattress, suction, hospital bed. Sometimes patient need CPAP machine, sometimes maybe discharged with oxygen concentrator, sometimes patient may be discharged with BiPAP machine. Itu semua kita bantu pesakit berdasarkan permohonan yang dirujuk oleh pegawai perubatan ke Jabatan Kerja Sosial Perubatan. Okay. The third one is nutritional support, is regarding the susu khas lah. Ini pun banyak dirujuk kerana kebanyakan warga emas ada isu of makanan dan memerlukan special make untuk pemakanan. Nutrient diabetic, nutrient fiber, peptamen. Susu ni kira expensive. For example, nutrient fiber kalau 400 gram tu near 550 ringgit per tin. So if you calculate by day or by 15 tin per month, so you calculate lah, maybe become 1,500, 2,000 for susu only. Peptamen also lagi mahal, 100 kalau 15, 1,500 for monthly. So bantuan lain serupa angioplasti. Some warga emas ada isu-isu berkaitan dengan kardio, ada block, so the pakar ask for the angioplasty, so kita akan bagi bantuan lah. Now angioplasty the costing quite increase, so now 15,000 per case usually lah, dirujuk tu 15,000, so quite expensive the cost. So kita trying also to get fund from the others. Okay, nanti I ceritakan where we get fund from the others. Okay, so implant ni biasalah. Alright, banyak case especially orthopedic, orang tua jatuh memerlukan bantuan plate sebagainya, so kita bantu. PICC is biasanya because of ada infection, you need antibiotic, so doctor refer for PICC around 7 to 800 per PICC, so kita memberikan bantuan from our tabung. So lately ni ada satu ujian plasma test yang dirujuk, so kita membantu perkara ini juga. So hopefully kita dapat satu result yang baik lah after bantuan ini diberikan lah. Plasma test ni is 1,008 per test, so quite expensive actually. Kalau satu bulan ada 10 patient, quite expensive, but we try to discuss further lah later. Okay. So this one very important. Ini penting kerana kita kena tunjukkan macam mana you all boleh, ataupun pesakit boleh dapat bantuan. Biasanya pesakit di PPM ni dia ada dua kategori. Satu orang awam dan satu lagi under government, pensioner or government staff or badan berkanun. Dia different bantuan yang diberikan. So social worker akan bantu pesakit only for non-government patient, especially for kewangan lah. Kalau kita cerita dari segi aspek kewangan, kita tabung yang dikendalikan oleh social worker hanya membantu pesakit-pesakit yang bukan kaki tangan kerajaan. Ini kerana kaki tangan kerajaan dia dah ada fund dia sendiri, yang mana dia boleh mohon dengan yang saya akan ceritakan sebentar lagi lah. Okay. Non-government patient, kita gunakan tabung PPUM Care. We have tabung sendiri under PPUM Care. We have general fund for the PPUM Care, dan kita ada juga support tabung daripada institusi atau big corporate yang sudi memberikan bantuan kepada PPUM Care. Especially kita ada UEM, kita ada Speed 99 yang baru-baru ini memberikan bantuan sebanyak 2 juta. Kita ada juga Mr. DIY, kita ada juga Lembaga Zakat Selangor yang every year akan contribute to PPUM Care around 200 to 400,000. Also same like Batumal, also memberikan bantuan every year 300 to 500,000. Macam UEM, dia beri setiap every year dia akan bagi 500,000 tu tabung PPUM Care supaya kita boleh bantu pesakit-pesakit yang memerlukan. Okay. So cara memohon adalah kebiasaannya doktor lah di ward. Kalau ada waris di sini yang mungkin memerlukan bantuan, doktor boleh inform kepada doktor untuk doktor refer kepada social work department. Now referral semua menggunakan portal. So doktor tahu, you just kalau ada waris di dalam talk ini, just inform the doctor, please refer because I cannot afford to pay for the implant ke ataupun respiratory equipment ke or nutrition ke or any special drugs. So usually dekat ward doktor akan refer to me lah. So kita akan buat assessment sama ada you all pesakit-pesakit ni layak mendapat bantuan ataupun sebaliknya. So untuk government patient is not under social work department. So usually kita akan advise doktor to fill up borang GPA 109 dan pesakit-pesakit pesara ini ataupun relatif ataupun waris perlu membuat penghantaran ataupun permohonan borang ke Farm Selatan sekiranya pesakit itu pesara persekutuan. Okay. You kena ingat pesara ni ada banyak jenis kategori. Pesara persekutuan, ada juga pesara badan berkanun. If patient itu pesara badan berkanun, have to submit to badan berkanun lah. For example, dia adalah pesara MPPJ. So borang GPA 109 yang telah diisi oleh doktor bersama-sama dengan memo ataupun surat bersama-sama dengan quotation perlu submit balik kepada badan berkanun terbabit yang mana pesakit itu bekerja sebelum ini. Okay, contoh dia bekerja di MPPJ, PKNS, MBSA, itu badan berkanun lah, termasuk PPUM. Kalau PPUM, pesara PPUM kena submit tu bahagian sumber manusia PPUM untuk membuat permohonan. Ini bukan di bawah social work department, tetapi sekiranya kes itu dirujuk juga, kita akan advise bagaimana you all nak dapatkan bantuan peralatan ataupun susu. Ada kadang-kadang doktor pun tak tahu dia ni pesara ke bukan ke, doktor akan rujuk juga. So tak ada masalah untuk social worker do the assessment. So kita akan buat assessment, tengok kalau pesara ini caranya. Kita akan explain to the relative, to the family tentang bagaimana untuk membuat permohonan ke jabatan ataupun kalau pesara persekutuan di Farm Selatan, kalau pesara badan berkanun balik kepada majikan masing-masing. Ini kadang-kadang jadi masalah kerana certain pesara ni jauh, bukannya pesara di Klang Valley, sometimes pesara di Perak, pesara badan berkanun di Johor, di Melaka. So ada sedikit kekangan di sinilah. Tetapi of course the procedure, anything about bantuan kesihatan, bantuan perawatan kepada pesara kena balik kepada majikan masing-masing. Kalau pesara persekutuan seperti KKM senang, dia under Farm Selatan. Pegawai farmasi akan uruskan permohonan yang dimohon lah. Okay? Right. Itu berkaitan dengan implan, bantuan kewangan berkaitan dengan implan, rehab, respiratory equipment, nutrition dan special drug. Ini dia punya konsep of bantuan, bagaimana nak dapatkan bantuan. Okay, ini borang perubatan 109 ni saya tunjukkan sebagai contoh. Kadang-kadang pesakit pun tak tahu sebab dia tak pernah sakit sebelum ni kan. So bila masuk hospital baru tahu borang 109 bagaimana nak isi. Kadang-kadang doktor pun di confuse how to fill up. So kita akan advise doktor lah. Kalau di ward kebetulan kes tu dirujuk, kita akan advise how to fill up with the memo. Sometimes majikan akan minta memo, dia tak minta only the form only, dia ask for the surat sokongan ataupun memo. Okay, itu borang 109. Ini jumlah bantuan mengikut klinikal pada 2024. Ini just untuk information saja, mana kita telah memberikan bantuan kepada pesakit-pesakit di PPUM. Kalau ikut geriatrik sini, dia termasuk dalam kategori multidisiplin lah. So kita tak dapat categorize under patient geri. So kalau dekat multidisiplin tu sebanyak 2.4 juta bantuan telah diberikan kepada pesakit-pesakit di PPUM yang clinical multidisiplin, di mana I think 10% or 15% from bantuan tersebut adalah di clinical geriatric. Okay, around 200,000 lah. Same like macam psychiatric, I in charge before psychiatric, around 215,000 per year bantuan yang telah disalurkan. Total around Kalau you tengok sini, orang boleh pergi sampai 5 hingga 7 million per year. So that's why kita ada banyak program untuk mencari dana untuk membantu pesakit-pesakit di PPUM. Ini just information. Okay. So bagaimana pula sekiranya pesakit-pesakit inginkan bantuan sara hidup bulanan? Ini penting. Kebanyakan pesakit dia akan request how to get the monthly allowance, because I'm not working anymore, I'm not pensioner, I'm not penerima bantuan ilat. So bagaimana nak dapatkan bantuan sara hidup bulanan? So ada dua cara yang boleh dapatkan bantuan sara hidup bulanan. Ini bukan cerita pasal BRIM ke SARA ke apa kan? Ini different. Ini monthly punya bantuan. Okay. Yang pertama adalah di bawah Jabatan Kebajikan Masyarakat Daerah. Okay. Ada pelbagai kategori bantuan, di mana yang pertama bantuan OQ tidak bekerja. Yang tak bekerja dapat 300 sekiranya betul-betul pesakit ni memang poor ekonomi, poor sosioekonomi, tak ada pekerjaan, tidak ada relatif yang mungkin pendapatan anak-anak pendapatan yang memang minima or B40. Bantuan orang tua 60 above ini bantuan adalah 600 sebulan. Nanti orang tua kita kategorikan dia sebagai umur 60 ke atas lah kan. So bantuan yang diberikan oleh JKM standard is 600. Dia tak ada minimum. Dia ikut 600 sebulan. Okay. Bantuan untuk OQ bekerja, ada orang OQ tapi bekerja, kita JKM akan bagi bantuan sebanyak 450 sebulan. Sebab apa? Sebab nak menggalakkan you all bekerja dan you akan dapat additional bantuan. If compare dengan tidak bekerja tadi, dapat RM300 only. Okay. So ada juga kategori bantuan pesakit terlantar. Ini untuk penjaga penjaga pesakit terlantar di rumah yang mungkin pesakit PPUM boleh memohon bantuan pesakit terlantar. Mana penjaga yang menjaga di rumah, isi rumah yang ada pesakit terlantar boleh memohon bantuan pesakit terlantar di Jabatan Kebajikan Masyarakat Daerah dan akan diberikan bantuan sebanyak 500 sebulan. Okey. Semua bantuan-bantuan ini boleh dimohon dengan menggunakan form JKM 18. Nanti saya akan tunjukkanlah form JKM 18 di mana mereka boleh menggunakan form ini. Sama satu form boleh guna untuk keempat-empat kategori bantuan. So but family or the relative kena submit the permohonan lah, okay, ke JKM terdekat. For example, kalau you tinggal di Subang Jaya, you kena submit di Jabatan Kebajikan Masyarakat Subang. Sekiranya you tinggal di mana, dikatakan di Kuala Lumpur, di Bangsa, you kena submit tu, ataupun tinggal di pantai Bangsa ni orang kata orang banyak duit. So kalau you tinggal di Pantai Dalam for example, you kena submit ke Jabatan Kebajikan Masyarakat Kuala Lumpur, mengikut daerah you tinggal. Kalau orang Petaling Jaya, dia kena submit kepada Jabatan Kebajikan Masyarakat Petaling. Okay. Itu untuk permohonan bantuan sara hidup. Yang kedua, Majlis Agama Islam Wilayah ataupun Lembaga Zakat Selangor juga memberikan bantuan sara hidup bulanan. Ini kalau you all dapat kategori dia jadi fakir miskin lah, asnaf fakir miskin. Ada juga pesakit-pesakit daripada geriatrik yang mendapat bantuan daripada Mawib ataupun Lembaga Zakat Selangor. Dia minimum 500 tak silap saya sekarang. So saya tak sure. Ada juga bantuan tempat tinggal yang diberikan sekiranya betul-betul susah, nak sewa bilik pun tak mampu, nak sewa rumah pun tak mampu, bantuan ni diberikan. Zakat akan bayarkan sewa rumah kepada owner rumah tersebut. Ada pesakit saya dapat 800 sebulan, ada yang dapat 600 sebulan, ada yang dapat sewa bilik 400 sebulan. Different category of amount kelulusan because of the different, bergantung kepada tempat tinggal tersebut lah. Ada yang tinggal di rumah flat, ada yang tinggal di bilik saja, jauh, ada perbezaan. So permohonan ini boleh dibuat di lembaga zakat ataupun Majlis Agama Islam Wilayah dengan menggunakan borang permohonan agihan zakat. Okay. Kadang-kadang dalam borang tersebut ada part yang diisi oleh imam, pegawai kumpulan A dan sebagainya. So sekiranya pesakit di PPUM, pegawai di Jabatan Kerja Sosial Perubatan boleh isikan di belakang tu. So tak perlulah pergi mencari imam ke, tak pernah pergi masjid, tiba-tiba nak kena cari imam dekat luar kan. So you all akan panik lah. So susah lah macam ni lah. Saya tak nak mohon lah, menyusahkan, banyak birokrasi sebagainya kan. So ada kadang-kadang orang tak memohon disebabkan perkara-perkara begini. So kalau you pesakit PPUM, dirujuk ke Jabatan Kerja Sosial Perubatan, pegawai tersebut boleh isikan borang tu untuk pengesahan, dan lagi mudah you all akan dapat bantuan lah, sebab pegawai di PPUM telah sahkan bahawa you all adalah kategori pesakit-pesakit yang mungkin yang tidak bekerja, tiada pendapatan, ataupun bekerja tetapi mempunyai tanggungan yang ramai disebabkan anak yang ramai dan anak-anak masih bersekolah. Ada pelbagai kategori bantuan lain sebenarnya, tapi dalam konteks geriatrik ni, inilah bantuan yang boleh dimohon. So satu lagi, ini borang-borang yang saya mention just now, itu adalah borang JKM 18, tak berapa clear tapi this is for information lah kan. So yang kedua adalah borang permohonan agihan zakat. Ni first page. The second page tu ada part yang pegawai kumpulan A ataupun penghulu, ketua kampung kena isi. Tapi untuk kes yang di PPUM, pihak kami boleh isi ataupun saya pun boleh isi untuk you all dapatkan pengesahan. So tak perlu pergi cari ketua kampung, penghulu, sebagainya untuk dapatkan pengesahan. Okay, yang ini yang popular, bil hospital. Ini popular. Sebab apa? Sebab bil hospital di PPUM ni sekarang memang agak expensive lah. 300 satu hari. So kalau duduk 10 hari 3,000, pening kepala. Bukan kata patient, kadang-kadang kita sendiri kalau alaminya pun akan rasa burden. 300 per day. So how to get the bantuan? So untuk bil hospital, untuk pengurangan ataupun penangguhan bayaran boleh dibuat di ground floor Menara Selatan di unit taksiran. Ini tak ada, social worker tak ada kuasa untuk menentukan berapa cik kena bayar, berapa penangguhan boleh dibuat, berapa bayar, kemudian bayar berapa. Ini bukan under social work department. This one under Jabatan Taksiran ataupun unit taksiran PPUM. So pesakit-pesakit yang mempunyai masalah hospital bill boleh berjumpa dengan pegawai taksiran untuk memohon penangguhan bayaran ataupun pengurangan ataupun pengurangan bayaran lah. Biasanya dia tak bagi pengurangan, dia akan bagi penangguhan. Berapa you mampu bayar pada masa hari ini? Contoh bil you 5,000, you hanya bayar 1,000. You have to discuss, you mampu bayar 1,000, you have to discuss dengan pegawai taksiran tentang bayaran tersebut. Kalau tidak kan tak boleh discharge. Tunggu lagi 1 hari, naik lagi RM300. So kadang-kadang tak fair juga kalau perkara itu berlaku kan. Only isu sosial tak boleh bayar bil, kena tunggu lagi, kena stay ward. Bila stay ward bukannya free, you kena tambah lagi RM300 per day. So kita elakkan perkara ini berlaku. So kalau berlaku perkara ini, please jumpa pegawai taksiran untuk discussion. So mungkin ada cara yang akan dia advise. So bagi Muslim patient, dia ada Majlis Agama Islam dan Lembaga Zakat Selangor ni boleh mohon, dan pihak saya pun boleh buat permohonan kepada pihak Lembaga Zakat ataupun Majlis Agama Islam untuk bil hospital. Ini ada bantuan daripada Lembaga Zakat dan Majlis Agama Islam. So biasanya tak ada masalah lah. Tapi untuk keluar ward, you all still kena jumpa pegawai taksiran. Sebab you akan mention, saya akan mohon dengan Lembaga Zakat minta penangguhan. So dia akan bagilah kebiasaannya. So kalau you tak settle juga penangguhan penangguhan bayaran itu dalam masa 1-2 bulan, nanti akan dapat notice from taksiran lah, unit taksiran berkaitan dengan bil yang tertunggak. Maksudnya you kata nak tangguh, nak mohon Lembaga Zakat tapi you tak buat kan, cakap je tapi tak buat. Ada juga yang macam tu. So bila dah keluar tu buat tak tahulah. So you akan dapat notifikasi. So better kalau dah janji, dah ada deal dengan pegawai taksiran untuk mohon bantuan daripada Lembaga Zakat, please do dan make sure dapatkan bantuan. Otherwise dia akan hantar you surat merah dan you akan mengalami emosi yang tak tentu hala, tak tentu arah. Akan cari saya balik, cari macam-macam lah. You all akan beritahu saya, you janji itu nak bantu, saya tak cakap pun, tapi you yang bila dalam panik macam-macam yang akan ni. Okay. So untuk bil hospital, kalau you pemegang kad OKU, penerima bantuan JKM, zakat tu free lah, tak perlu bayar lah. Ini yang penting. Kadang-kadang orang duk nakkan sangat bantuan kad OKU ni because of nak dapatkan bil hospital percuma di PPUM. Kalau penerima bantuan JKM dapat 400-500 sebulan, also percuma di PPUM. So tak perlu risau. Tapi kena bawa lah surat. Jangan cakap terima tapi no bukti. So siapa nak percaya you? Kita ramai patient beribu-ribu. So kita tak boleh nampak, oh muka ni JKM, muka ni zakat. Tak ada, kita tak boleh trace kan. So kena bawa dokumen kad OKU ataupun penerima bantuan, surat pengesahan penerima bantuan kewangan dari JKM ataupun zakat. Actually pegawai taksiran ataupun pihak saya boleh trace you by system. Kalau ada IC kita akan trace, kita boleh tahu you ada penerima bantuan ataupun pemegang kad OKU. Kadang-kadang tertinggal kad lah, tertinggal surat lah sebagainya, kita boleh trace by system. But better bawa kad ataupun surat pengesahan supaya you layak mendapat rawatan percuma di PPUM. So next is berkaitan dengan counselling and emotional support. Yang ini ada juga kes-kes yang dirujuk untuk bantuan sokongan emosi, dan biasanya social worker akan buat sokongan emosi ni after rujukan lah. Dan biasanya kalau kes-kes yang regarding discharge issue ni, kita akan buat family conference. Ini saya takkan sentuh detail lah. Okay, ini tadi telah disentuh oleh penceramah sebelum ni, emosi-emosi pesakit yang berada di ward, pelbagai jenis emosi yang berada di ward. So ini saya takkan sentuh. Tetapi sekiranya mereka ingin, sometimes kadang-kadang orang nak meluah perasaan, nak bercakap kan, ataupun just nak dapatkan himat pandangan sebagainya, nak bercerita, ni tempat-tempat yang boleh you dapatkan lah. Okay, contoh kalau di PPUM ni boleh refer di Jabatan Social Work, ataupun kalau mereka dah ada simptom-simptom demensia dan sebagainya, mungkin boleh refer kepada Jabatan Psikologi lah untuk lihat lebih detail lah. Okay, untuk ada yang depression kan, ada certain pesakit mengalami masalah major depression, boleh rujuk di social work also, dan rujuk di Jabatan Perubatan Psikologi. Dan untuk di luar daripada PPUM, kita ada Jabatan Kebajikan Masyarakat, kita ada NGO, WAO, ada awam, ada befriender dan sebagainya. You all boleh call untuk mengadu, untuk bercerita masalah, untuk mendapatkan khidmat nasihat. Ada pegawai yang akan entertain. Okay, ini contoh salah satu aduan masyarakat yang inisiatif by Jabatan Kebajikan Masyarakat di talian kasih 1599. Ada pelbagai aspek masalah yang mungkin berlaku, you all boleh call. Ada isu kaunseling, ada isu penderaan, pembuangan bayi, talian kanak-kanak, perlindungan, warga emas, perkhidmatan, kesihatan reproduktif dan masalah sosial. You all boleh call di talian tersebut untuk mendapatkan pandangan dan mendapatkan khidmat nasihat, dan mungkin selepas itu boleh membuat permohonan lah, especially berkaitan dengan social support, emotional support, boleh rujuk juga kepada JKM, boleh buat appointment untuk berjumpa dengan kaunselor terbabit. Okay, salah satu perkara yang penting juga adalah berkaitan dengan discharge issue, di mana pesakit-pesakit di ward ada isu discharge ke mana after settle the treatment. Because of biasanya yang pertama kerana satu, tak ada keluarga, warga emas yang tiada ada keluarga. Yang kedua, kemungkinan ada keluarga tetapi keluarga tidak tahu cara penjagaan kan, tak tahu cara menjaga, ataupun keluarga tidak mahu menjaga. So keluarga tak tahu apa nak buat. So that's why sometimes kes dirujuk kepada pihak kami. Okay, kebiasaannya bagi pesakit-pesakit yang ada isu yang especially yang tak ada record, identifikasi, kemasukan ke ward without identifikasi pun boleh mendapatkan bantuan daripada pihak social worker, di mana kita akan buat assessment, dan sekiranya mereka masuk without the IC, without the license sebagainya, kita akan rujuk kepada JPN untuk mendapatkan maklumat detail berkaitan dengan pesakit tersebut. Dan sekarang JPN Kuala Lumpur very fast. Kalau you rujuk hari ini, you just WhatsApp pegawai tersebut, mungkin esok ataupun lusa dia datang dengan van dia untuk bawa all the equipment untuk test. So once dia datang with the test cap jari, masa tu juga boleh tahu whether pesakit ini warga negara ataupun tidak. Saya ada kes yang dia boleh buat cepat, dia tengok, oh ni nama is Muhammad bin something, very fast. So the technology very good now, so boleh dapat. But I have to, social work department kena rujuk kepada JPN lah. So ada pegawai GPN yang bagus-bagus ni, kita WhatsApp je, dia layan dan dia akan hantar dia punya staff. Dan lepas tu baru kita buat surat. Kadang-kadang dia minta buat surat dulu, itu yang jadi lambat tu. Biasanya kita nak cepat, di hospital kita nak cepat, dan kita akan WhatsApp pegawai tu minta bantuan. Ada juga yang ada IC tapi tak ingat all the contact number of family members, lupa. Ada kes yang buat-buat lupa pun ada, saya jumpa. Sebenarnya dia ingat, dia buat-buat lupa sebab dia nak masuk kat ward, nak duduk rehat lama sikit. Ada, tapi dia buat lain lah, bukan dia buat geriatrik. Buat psychiatric. Bila kita tahu, oh ni memang dia, next time dia masuk kita dah tahu. Okay, alright. So untuk yang tak ingat all the information family, kita akan kalau dia ada IC senang. Kalau confirm patient tu ada IC, then easy. Kita akan dapatkan information from GPN, kita akan hantar the number IC, GPN akan bagi all the information. Anak berapa, okay, contact number berapa, berkahwin atau tidak, boleh dapat information. Dengan syarat dengan adanya IC. Some patient ada IC masuk tapi lupa semua all the family members. Memang lama tak contact, so dia tak tahu macam mana nak contact the family. Ada juga begitu. Okay. Sekiranya pesakit-pesakit with family yang ada tetapi family tak tahu how to settle this patient after discharge, biasanya social worker akan discuss regarding the placement lah. So usually kalau refer for nursing home tu, kita akan provide a list of nursing home yang ada. Sebagai contoh, dekat sini kita ada Christina Home Care, kita ada Eki Mega Home, Expensive Care Home dan sebagainya. Kita akan bagi with the costing yang mungkin mereka akan rasa ni boleh, ni tak boleh kan. Sometimes patient dia ada budget dia sendiri. So usually we akan inform lah, this Christina how much, Mega Home how much, Impressive how much. So depends. But the choose of nursing home is under family lah. Kita tak bantu untuk, kita tak decide untuk family choose which nursing home yang pesakit perlu. Okay. What happen if patient or relative cannot afford to pay the cost of nursing home? Ini jadi masalah. Family tak boleh jaga dan family also tak berkemampuan untuk membayar kos nursing home. Di Klang Valley ni hanya Lembaga Zakat Selangor sahaja yang membantu pesakit tinggal di nursing home. Ini satu yang perkara yang saya pujilah tentang Lembaga Zakat Selangor. Dia membantu pesakit saya 2,000 sebulan. Ada yang 1,800, ada yang 2,000. Tapi maksimum saya dapat tahu is 2,000 per month. Depend on the socio-economic patient lah. But if patient tu memang poor dan charge of nursing home is 2,000, zakat akan bayar 2,000 every month until 1 year. Then akan continue if patient still stay in the same nursing home, ataupun stay di nursing home. So tempat-tempat lain, jabatan kerajaan lain ataupun Majlis Agama Islam Wilayah tak ada bantuan for nursing home. Only Zakat Selangor lah. So kalau yang lain-lain tu, kita try to get what? Kita try to dapatkan nursing home percuma. Yang mana ada dua kategori, pusat jagaan yang boleh memberikan rawatan percuma. Kategori kerajaan under JKM, Rumah Seri Kenangan dan Rumah Ihsan. Ini kalau nak mohon, kena pergi ke JKM ataupun menggunakan talian 1599 tadi. For example, patient ada di ward, dulu ada kes Pak Cik Tahir kan, di ward 13U tu, kita gunakan talian 1599 supaya JKM datang untuk buat assessment dan plan for discharge. That one free lah under JKM. Tapi you know lah, free ramai. Ramai dan agak availability dia agak kurang lah, agak sukar untuk mendapat tempat. Kalau NGO, kita ada kontak-kontak pusat jagaan tertentu yang boleh kita discuss untuk mendapatkan penempatan percuma seperti yang saya mention di sini, seperti Lovely Nursing Home, PJ Caring Home, pusat jagaan Jing Wan di Setapak, Rumah Nuasana dan Warga Tua Damai. Ada few tapi not easy also, sometimes based on availability lah kan. Kalau dah free semua orang duduk situ mestilah penuh, so kadang-kadang agak sukar juga. Tapi we try lah to nego with the owner, supaya pakcik-pakcik ni, kita punya makcik tu, warga emas ini mendapatkan penjagaan selepas discharge, yang mana kebanyakan mereka ni single ataupun family pass away dan sebagainya lah. So tidak ada ahli keluarga lain. Kalau ada ahli keluarga pun kadang-kadang mereka tak mampu membayar to bear the cost of nursing home. So refer to social work akan plan how to get the nursing placement, dan kita akan discuss with the JKM or NGO. JKM ni selalu tak ada kosong lah, so kita trying to find NGO dan kita akan deal with NGO tersebut lah untuk mendapatkan penjagaan percuma kepada pesakit. Okay, so the last one before session ni end, kita I just nak inform about OQU, submission of OQU practical assistant yang dijalankan oleh social work department untuk membolehkan pesakit-pesakit mendapatkan OQU. Ni contoh gambar kat OQU ni kawan saya. Dia adalah OQU masa saya study di UM dulu, dia memang OQU buta sejak lahir. Sekarang dia adalah pegawai Jabatan Kebajikan Masyarakat di Putrajaya. Ni lama tak jumpa ni. Dia memang blind sejak ni. Dia kahwin also with the blind people, but anak-anak semua boleh melihat. So dia pergi mana-mana, anak yang bawa dia pergi jalan, pergi shopping sebagainya. Ini rakan baik saya lah. Okay. So untuk dapatkan kad OQU ada dua cara lah. Satu, untuk submit to Jabatan Kebajikan Masyarakat Daerah dan Negeri, mesti di fill up oleh patient itu sendiri atau waris, dan mesti ada pengesahan pegawai perubatan. Dan the third one condition is IC dan pasport. Gambar pasport mesti ada. Jangan tak ada IC, tak ada pasport, tak ada, then difficult to get the OQU. Alright, so within approval dia biasanya 2 to 4 weeks. Dan sekiranya pesakit itu di ward geriatrik tidak ada siapa-siapa, ataupun di ward mana-mana memang tak ada relatif dan sebagainya, pihak social work boleh bantu untuk membuat permohonan di JKM untuk mendapatkan kad OQU. Dengan syarat 1, 2, 3 itu ada. Yang susahnya bila gambar lah kan. Patient ni dekat ward semua, macam mana nak dapat gambar pasport. So apa yang kita buat biasanya, kita ambil gambar dia di ward tu, guna handphone sendiri, edit sendiri dan submit to JKM. Sometimes JKM terima, sometimes JKM reject. Tak cantik lah gambar ni pun, semua kena ambil balik gambar. So kena buat sampai betul-betul jadi. Then so far apa yang pernah kita lakukan sebelum ni memang diterima dan diluluskan. Especially for patient yang tak ada waris, relatif pun tak ada, dia pun pakcik tu pun terlantar, tak boleh buat apa. Why kita nak apply dekat OQU? Memang dia OQU kan, so nanti bil hospital dia free lah kalau dia dapat. So tak perlu risau tentang bil. Saya pun tak perlu bergaduh dengan pegawai taksiran tentang pesakit-pesakit begini. Sebab social worker pun biasanya deal dengan taksiran. Itu pun kadang-kadang ada juga isu-isu yang perlu dijelaskan. Bukannya senang. Okay. So kalau ada kad OQU, social worker pun akan rasa lega sikit lah. So tak perlu doktor tanya pasal bil sebagainya. Okay. So kalau pesakit tu tak ada waris, dan kita akan bantu. Jangan risaulah, bukan kita biarkan. Kita try tu bantu patient untuk dapatkan kad OQU. Yang penting rawatan dia after discharge tu, dia nak datang balik, follow up di klinik dan sebagainya, sudah dapat percuma because dia ada kad OQU. Kadang-kadang kalau pegawai di JKM tu cepat, sekejap je. Kalau complete form 1 week pun dah boleh siap. Kadang-kadang saya pernah push 2 hari boleh lepas. Ini different pegawai. Okay, so kita kena ada cara lah nak bercakap dengan pegawai-pegawai kerajaan ni. So kena pandai-pandai. Puji-puji sikit kalau yang perempuan tu. Okay, ni contoh-contoh lah. Gurau. Okay, sekarang kad OQU ada perbezaan. Dia ada perbezaan, dia ada kad apa ni? Ada what we call, dia ada ni QR. Ada beza. Kalau siapa yang ada kad lama minta tukar ke Jabatan Kebajikan Masyarakat. QR ni you ambil gambar, you akan nampak lah all the detail, surat pengesahan, surat kelulusan, OQU bila dapat. Ni inisiatif terbaru lah. So kalau you all ada, pergilah JKM sana untuk tukar baru lah. Sekarang kalau kelulusan JKM, dia akan hantar pada pihak kami juga by surat. By surat kita boleh check by online. So kita boleh print dan kita boleh ambil gambar dekat what you call the QR tu, kita boleh nampak all the card OQU. Dekat surat pun kita boleh tahu. Dengan syarat surat tu ada QR. So kita boleh tahu all the card OQU dia sebagainya. So teknologi dah bertambah canggih. So kita kena follow lah. Alright. So siapa-siapa yang ada kad OQU yang lama boleh minta bertukar kepada kad OQU yang baru. Alright. So itu saja berkaitan dengan servis dan bagaimana bantuan boleh diperolehi Saya rangkumkan sekali lagi. Bantuan tadi kita explain ada 4 perkara. Yang pertama tadi berkaitan bantuan kewangan, kita ada isu sokongan emosi, kita ada berkaitan dengan discharge, dan akhirnya tadi bantuan praktik berkaitan dengan kad OQ. Itu perkara-perkara utama di dalam di clinical geriatrik ataupun kebanyakan clinical di hospital ni yang dirujuk kepada pihak social work. So itu saja, harap talk ini dapat memberikan sedikit knowledge ataupun informasi. Yang mana rasa sukar nak dapat bantuan, please datang to us to discuss. Jangan buat nandaian persepsi dan sebagainya. Kadang-kadang orang suka persepsi-persepsi yang negatif tentang bantuan, kan? Kita tak nak. Kita cuba bantu dengan cepat. Even kalau kat PPUM, I think antara yang paling cepat lah untuk mendapatkan bantuan, especially bantuan susu, alat sebagainya, sebab kita menggunakan sistem online daripada gunakan kertas. Itu saja. Sekian, terima kasih.
Thank you Tuan Muhammad Yazil bin Mahmud to give insight on where and how to get support to our elderly person and their family members. Thank you, Puan. And now, let me introduce to our final speaker for today, Dr. Kejal Hashmukarai, who is specialist in geriatric medicine at the University of Malaya. She received her postgraduate training and her higher specialist training in geriatric medicine at University of Malaya. Dr. Kejal is actively being a membership for Association of American Medical College since 2025, Malaysian Society of Geriatric Medicine, and American College of Sport Medicine. She has been receiving various awards, including Inspire Award 2025 from Faculty of Medicine University Malaya, Certificate of Excellent Service 2024, and Australian Award Fellowship Capacity Building for Aged Care in Asia Pacific. Now, let's welcome Dr. Kejal, geriatric consultant, who will talk about the quiet crisis, elder abuse in Malaysia, voices that must be heard.
Thank you very much, Miss Amira, for the kind introduction. Hi everyone, good afternoon. This is basically the tail end of the webinar. Happy International Day of Older Persons to all the listeners who are listening, tuning in, and even those who are going to be tuning in to us a little bit later, because I do hope and believe that the entire webinar session has been very informative. The theme of this year's International Day for Older Person is the older persons driving local and global actions, our aspirations, our well-beings, and our rights. But I also wanted to take this opportunity to talk about the voices that are often not heard of our older persons, the quiet crisis of elder abuse in Malaysia, a voice that we must now learn to hear as loud as possible and be aware of what potentially can be going on. This is essentially... Sorry. So this is basically just a disclosure of my talk. It's purely based on peer-reviewed literatures and on my own opinions. Sorry, this is also just the outline of what we'll be discussing about, and I'm happy for you all to put in some questions in the chat, and we can try to answer them a little bit later. So why did we decide to talk about this? Is really, I think all colleagues before this has already addressed that it is an aging nation. We are now aging, and fast forward in 30 years, we're going to be a super aged society. And what's interesting for Malaysia is countries like France took 115 years to become a super aged nation. But Malaysia, just like Japan, is going to be aging very rapidly. And if we don't embrace ourselves to prepare for the aging population, we're probably in for lots of troubles. And this is just some statistics. With aging populations comes problems that potentially comes with an aging nation too. Studies have shown, this is basically a report from the World Bank, that people who will have functional limitations is projected to double by 2040. So for what we have now, it's probably going to double by 2040. And the number of people who are going to be dependent in their ADLs, which are activities of daily living, is projected to increase by about 1 million per decade. So you can imagine the amount of issues that we might face if we don't start preparing for this At this point, as we are speaking, it's estimated about 250,000 older persons with dementia have their cares unmet. And to be honest, this is probably a number that is underreported as well. The National Health Morbidity Survey in 2018 reported that 1/3 of our patients who are more than 60 years old in Malaysia are malnourished. 1/3 of those who are aged more than 60 have poor social support. And when you think about poor social support, malnourished, the few things that comes into our mind is potential abuse, neglect. And if we think that this is something that doesn't happen in our country, I just wanted to bring up to you some newspaper articles that had happened. So this is reported during COVID, during PKP, of parents being abused by children, and the percentage has gone up to about 20%. This is another article where the father was was abandoned on the side of the road. This is an engineer who actually sent the family member to a nursing home and yet claimed that he's not the son, and said that he's basically just a relative or a friend. These are not one-off. There have been many cases that have been reported, and I would like to believe that every case that's reported, probably 3 or 5 or many more cases goes unreported. From a report in 2022 that was published in an article, said that 1 in 11 older persons in Malaysia were at risk of neglect and abuse. Think about it. The number may be higher because we're not aware, or we probably just want to keep it hush-hush under the carpet. And in line with this, the Malaysian Society of Geriatric Medicine did come up with a position statement on elder abuse and neglect. And I'm here to just create the awareness so that we understand and we keep our eyes, ears, everything open so that we can better care for our older persons. And to be honest, abuse can happen anywhere, in our home, in care facilities, whether it's in hospitals, in aged care facilities, it's anywhere. So unless we keep our eyes open and we're aware of what potentially can be going on, this would probably just pass as nothing at all. So some definitions to understand better: physical abuse is inflicting or threatening, inflict physical pain or injury on a vulnerable elder or depriving them of basic needs. Emotional abuse is inflicting mental pain, anguish or distress on an older person. It can be through verbal or non-verbal acts. Sexual abuse is non-consensual sexual contact of any kind. Exploitation is illegal taking, misuse, concealment of funds, property or assets of a vulnerable older person. Neglect is refusal or failure by those who are responsible to provide food, shelter, healthcare and protection for a vulnerable older. And abandonment is desertion of a vulnerable elder by anyone who had assumed the responsibility for the care or custody of that person. Why does abuse or neglect really happen? Often it's not intentionally done, but it's basically a reaction to what's already going on. So the high level stress of the caregivers, whether it's dealing with the financial burden, trying to make ends meet in this current day and age when the cost of living is so high, trying to make ends meet, or it could also be the emotional dependence of that older person. So the victim is basically the main provider of the financial, and so the caregiver uses that opportunity to then abuse or neglect, or the caregiver themselves could be undergoing some mental health issues like depression, or they are under some alcohol or substance abuse that leads them to be very disinhibited and then having temperament. Or there's also just carer burnout and stress. Sometimes things are not meant to happen, but it happens because we just burn out. We don't really know how to care for the older persons, and there's lack of social support. And if it's just one child looking after two of the other older persons in the family, it can be quite stressful. So I'm just going to go through with you some of the examples of abuse so we can keep our eyes open and know that this can also happen in our backyard. So physical abuse includes hitting, twisting, scratching, rough handling of older persons, burning, scalding, unnecessary use of restraints, locking into a room or furniture. If you think about it, you would think that a lot of this don't happen in our country, but many of these pictures are actually taken from our local media. And what are some of the signs that we can look out for when we are suspecting someone to have an abuse? I intentionally gave you the physical signs and the gestures because our older persons don't really talk about it. We're very respectful community that we like to hush things a lot. And I think these are some of the signs that we can look out for, like physical signs. If you're thinking of some physical injuries, look at particularly the wrists because that's where people can be mishandled, the arms, the legs. Looking for broken bones. Often patients don't complain or they're not in the capacity to complain because of cognitive issues issues, but you realize, for the last 1 week, they're not moving as much. Maybe there was already a sprain or a broken bone. Scalding of the skin, whether it's the back, the bottom of the legs. Ligature marks, because sometimes they are restrained by just, raffia string. So you can look for evidence of restraints. You can look for evidence of malnourishment, dehydration, repeated injuries. Sometimes it's just under or over medicated. For example, the person is made to be very sleepy throughout the day, just totally zoned out, and medications that are needed to control their comorbidities are not quite provided. So what can we do as caregivers, and when we are visiting our families, our loved ones, or someone that we know in in aged care facilities, even in our home, if we have got carers, even what we are doing to them, if we are not aware, look out for this kind of things, frequent emergency visits, because they're trying to tell you there's a problem, but they're just not wanting to say out what the problem is. Or on the other end, they just don't want to seek medical attention because they're trying to cover up what potentially could be visible. Refusal of the family members or the perpetrator to allow the victim to be seen by a healthcare provider. So they're always standing there so that you don't have a one-to-one session, so that the patients are not able to express or tell you what's really going on. Frequent no-show for clinic appointments, sudden change in behavior, becoming very quiet, showing as if though they're very fearful when that particular person is in the room. Watch for facial expressions, emotional discomfort. You can see they relax when that person or the person who's been doing harm to them leaves the room. Or you can also see that they change the way they start dressing. They start wearing long sleeves, scarves, because they want to cover up potential injuries. This is very not in keeping with our weather, because when it's so hot, we do not expect our older persons at home to be wearing all long sleeved and gowned up. So this probably could give us some clue on what is potentially happening to our older person. Now let's move on to emotional. That was physical abuse. Now moving on to emotional abuse. This is some of the things: intimidating or threatening a patient, ridiculing, insulting them, making a patient feel guilty, yelling, shouting at them. It's a bit different compared to those who have got hearing impairment, where we're trying to speak louder. It appears as if we're shouting, but it's just trying to accommodate to their needs. But we also have got answers for that, using hearing aids or voice amplifier, ignoring them, or basically giving them the silent treatment. They can keep talking and asking, you don't care about it, isolating them, preventing them from participating in social activities, terrorizing them, or even threatening them to not be given any food or water. And what are some of the things that you can look out for physically? They probably will just be rocking, pacing front and back because they know there is a problem, but they just don't know how to express it. Or you realize that from the last time you saw them, now they have got completely poor self-neglect, or basically very unkempt, not really looking after themselves. Some of the gestures that you can look for is changes in behavior, sudden withdrawal, not wanting to talk about, just keeping to themselves, the behavior like I mentioned, or you just see their facial expressions appearing to be very fearful and very abnormal emotional response, and just sudden withdrawal from social activities because they just feel not confident or very emotionally down to be joining any activities. Now, let me bring your attention to examples of sexual abuse. Sexual contact with an older person who is confused or unable to give consent. It could be just sexual contact or even penetration without the victim's consent. Forced nudity, photographing an older person in a sexual way without that person's consent. And when a person is delirious, by them just nodding, saying, smile, it's not taken as a consent. And this also includes hands-off offences, meaning just passing remarks or making sexual jokes and comments, or even showing them pornography. And I just wanted to bring to your attention, if you have not heard of this case, Sonja Fisher. Basically, her daughter had reported this, and it was a big thing in the 1990s or early 2000s. It was basically at 83 years old, lady with advanced Alzheimer's. This is what the daughter said. At 83, unable to speak, unable to fight. She was even more vulnerable when, as a little girl, she fled her homeland. So her mom had actually left the homeland for greener pastures. In fact, she was as vulnerable as an infant when she was raped. So what happened in this Sonja Fisher's case was basically she was in a nursing home and she was actually raped by a male caregiver there. And this, of course, then became a big issue in the media, and trying to see how we can now fight for the rights of our older persons. What are some of the signs that we can look out for? Is looking for physical signs, particularly bruises around the breast area, genital area, which we can easily see when we're doing diaper change or when we're doing sponging for them. Bruises or abrasion around the mouth, torn clothing, or you see some unexplained bleeding, whether it's coming from the anus or vagina, and frequently getting sexually transmitted infection. behavior signs that we can look. Inappropriate interactions, they can be unusually friendly or really, really, withdrawn, not wanting to talk much because they're very fearful, increased shyness, and that particularly happens when a person comes about, maybe because that is the person who has been inflicting it, and so they just withdraw from it. Hesitancy to even shower because they know the injuries would be visualized, or even just covering up, again, like, wearing long sleeves, don't want to be changed because they know this can be then be seen, and they don't want to report this because they are worried about what will happen to them if they report this. This is something really impressive in Nairobi. The instructors of self-defense program, they were training older persons to protect themselves from rape, because at one point the rape cases in Nairobi was really, really increasing, and with this self-defense that was taught to the older persons, they then could at least protect themselves, and even if they could not do much to do it as one person, as a team, they were able to raise the awareness, and eventually the rape cases did come down in Nairobi. Now let's move on to what exploitation in an older person really means. Could be telemarketing scams, and we all probably have been victim directly or indirectly of phishing websites and all that. Power of attorney fraud, because sometimes the older persons would have already written a POA, and then there could be a fraud or mishandling of what they had already priorly written. Befriending an older person just to get elaborate gifts because probably they are rich and they could afford it. Convincing an older person to hand over money or personal property. Maybe they're not in the right state of mind, they've got cognitive issues, and they just nicely signed off everything, forging the person's signature. Failing to pay for nursing home share of costs, so you just throw them or leave them in the nursing home and not paying for their care. Some signs to look out for: unpaid expenses. So for example, despite them having adequate income, but their expenses for probably the water bill, utensils, utilities and all that are not paid for. Missing properties. You realize unusual banking activity, suddenly a huge amount of money that was taken out. Unusual debit card or ATM card usages. Purchases of gift cards, which probably the older person had never thought of getting, but it's probably just part of a fraud or a phishing activity that was happening online. Phone calls that they take, they want to answer a call but they go into privacy because they're so worried they're being blackmailed. They're getting charges for international calls, for calls that they don't really make. So these are some of the things that we can look out for. Or you realize they now start talking of a friend that never existed in their life, someone who have been advising them so much about their finances. You realize they suddenly decide to change their power of attorney, or they've got documents missing. So some of these tells you that they are probably been exploited, and we can help them to really explore what really is going on with them. And finally, I also want to just talk about what neglect really means. Often this is not intentionally done. Sometimes we are not aware, but there are some things that we can also help where, they are not giving the persons that they care for adequate food, medical care, even suitable accommodation. They receive the carer's allowance, but the allowance is not used for the care of the older person. So a caregiver neglect is basically the failure of the person who has the moral obligation as a caregiver to provide the basic needs. And self-neglect is basically the failure of the person, meaning ourselves, that despite the ability to do so, we're not able to provide the basic needs for ourselves, be it for whatever reason, financial reason, emotional reasons, or just inability to do it physically. This is some evidences of neglect. Sometimes pressure injuries happen despite all our efforts. We understand. But sometimes it's completely not aware. Older persons are left bedridden for, in the whole day while we are working. So maybe we'll just need to find a way how we can help them so that their wounds don't get worse, because it can be really, really painful, keeping them on diapers, soiled and soaked. This picture of the porridge is basically a true picture of our patient who actually essentially only survived on plain porridge and Maggie mee for the rest of their, 6 months prior to them getting admitted to us for severe malnourishment. And we have also seen all the case reports that I've shown and highlighted earlier. So essentially, neglect is not something that's not new. Sometimes it can happen even despite us trying our best. But wherever we can, we need to start looking out for signs, whether our person that we care for is looking very unkempt, dirty, sudden weight loss, very poor appetite, dehydration, inappropriately realizing that there's just no food or lack of food preparations at home, untreated illness, broken equipments, like you can have wheelchairs and all that, but they're all broken, the tires are not working, the wheels are all not working, and so that it doesn't help. Missing eyeglasses, dentures, hearing aids, because then it's going to deprive the older person from functioning on their day-to-day, leaving them on soiled diapers. Some signs that you can see in facilities, if our parents or loved ones are in aged care facilities, they're just unusually dirty, in a cluttered living environment, very disconnected or disjointed utilities around, inappropriate housing equipments at home. They tend to miss appointments. They're left alone in that particular place for long period of time without even being cared for. Failure to get the care needed, and even failure for the caregiver to provide the assistance. And finally is abandonment, is the decision of an older person at a hospital, nursing facility, or anywhere. Like the case report was where they sent the family to a hotel and basically just left the older person there. It could even be to a mall, roadside, or the oldest person's statement themselves that I was being left and nobody cares for me now. This is what I had highlighted earlier. So the purpose of really bringing this is something that we hardly discuss about it, and we just hush it and sweep it under the carpet. But I think whatever has been reported in our media is probably just the tip of the iceberg. There are probably hundreds and thousands of cases that is probably still going on, and we don't realize that the true medical, economical, and societal burden of neglect and abuse can be really, really underappreciated. And I think all of us who are tuning in onto this really needs to play a role in reporting this. There are many barriers on why we don't want to report. We as the older person, maybe we don't have the cognitive capacity, neither we have the physical ability to go and make a report. We're not able to move. We're not aware of whatever that's going on around us is part of an abuse or even part of neglect. We don't know what our rights are. We are socially isolated, and we are worried that if I report, then I will be even more socially isolated. We want to preserve the family relationship because maybe the person who is doing it to us is part of a family. You are dependent on that person, so you don't want to lose the dependency. You're feeling very stigmatized, and you're ashamed to bring up the matter, or just the religious belief that it's okay, let it be, it just happened. Fear for that person, or even just worried that perpetrator would actually harm us more. So really a lot of barriers, and these barriers can only be overcome if each one of us start taking our voice and making sure that their voices are heard. How can we prevent this? I think specific education for all of us, whether we're caregivers, our loved ones, whether we are ourselves aging, we need to understand what our rights are, identify the abuse, establish a proper protocol. And if you are in a caregiving state, or in an aged care facility, or in a hospital, screen for abuse, look for all the signs that I've mentioned earlier, respond effectively. And I think it's important for us to continuously raise public awareness, such as this talk today. We need to strengthen social support so that the older person feels empowered, that they are able to look for some help elsewhere when they try to report this. And there needs to be collaboration between all of us. So what can you do for all of us who are listening? Recognize, ask, and report, right? It's important for us to recognize what's going on, ask the older person if they are being victimized, and report it. Use all our senses, be observant. If something does not look right, smell right, or sound right, extend the conversation in an indirect manner. Look for subtle signs. Consult a law enforcement officer if you need to, or even a social worker. Are there some legalities in Malaysia? Well, we have a DVA 1994 Act. We have certain acts that can help protect older persons. But I think there's some limitations as well, because it's not specific to the circumstances related to just elder abuse and neglect, because this is under domestic violence and acts. So it's not specific for elder abuse and neglect. So this is basically from the position statement of MSGM, talking about the pathway, what we can do. Just wanted to bring to your attention that if you suspect someone is having potential abuse or neglect, you can always walk into a one-stop crisis center in a hospital. Then they get assessed by the medical officers. If they are confirmed to have neglect, then there are some actions that can be taken by the social worker and also the medical team to make sure that the older person is safe and they do not go back to the same place where they were already victimized or abused prior to this. What can be done? I think my colleague before this, Tuan Yazil, has already showed Talian Kasih. So you can contact relevant agencies, the Women Aid Organization. You can take down this number number. This number definitely works. I had tried to check before I put this up to make sure that the line is still functioning. Talian Kasih is there. Second is the one-stop crisis center that I mentioned. It's available in every hospital that you can then mention about what's going on, and then the care will continue from there on. Or option 3 is obtaining an emergency protection order from the social welfare department, which is usually available 24 hours, often just by contacting Talian Kasih or visiting the nearest social welfare office. So this is basically bringing me to the end of the talk, and my take-home message for all of us, whether we're aging, whether we're caring for our older parents, our loved ones, is really the need of education and awareness. We need to be a bit more aware of what potentially can be going on for our loved ones in any facilities or even back home. Be aware of what can happen. Be older person's advocate. Whoever, not every one of us who have contacts with older person need to be their advocate for their best interests. RAR is basically recognize, ask, and report. And finally, I think we need to work together. There's no success in isolation. Even as a doctor, I can't do anything. We need to work together with my nurses, with my social worker, with my therapist, to try to understand what's going on and make a better plan for the older persons at home. With that, I thank you.
Thank you, Dr. Kejal, for the powerful and thought-provoking talk. It's a strong reminder of why we must continue to protect and care for our older person with respect and compassion. And that brings us to the end of today IDOP 2025 webinar. Before we close, a big thank you to all our amazing speakers for sharing their knowledge and experiences today, and to everyone watching from home. Thank you for spending your morning with us. Let's continue to take early action, support one another, and care together for our older community. Stay safe, take care, and have a wonderful day ahead. Thank you.